Have you, or anyone in your immediate family, ever served in the British Armed Forces? Ask the question. Did you know the number of veterans living in Great Britain is estimated at 2.4 million, with 1.8 million living in England and Wales? That's around 5% of the total population. It is estimated that around 5.8 million veterans and their families are living in England. There's a significant number of people from the armed forces community under our care. An estimated 14,000 veterans leave the armed forces each year. This can be a major life event, and for some can be stressful and filled with uncertainty. For those who have served in the armed forces, it is more than just a job. It can be a way of life and can provide purpose and identity. Because of this, some veterans can struggle with their mental health in addition to them being high risk for some long-term medical conditions. Veterans can be reluctant to seek medical advice and ask for help. This may be due to a mindset and attitude from time in service of just get on with it. It's this mindset which can prevent them from asking for the help they need. Veterans may need our support to ensure that they are able to access the additional or specialist services that are available to them. It is therefore critical that we ask the question, have you or anyone in your immediate family ever served in the British Armed Forces? Ryan, a former Royal Marine, left the services several years after multiple intense tours of Afghanistan, where he lost close friends and colleagues, which still affects him and causes him to struggle at times. Ryan has visited his GP, but doesn't want to make a fuss, so hasn't told the practice that he is a veteran. He's been referred to his local mental health services, but he doesn't think they truly understand what he's been through. They haven't asked if he served, and he hasn't thought to tell them either. Ryan's practice nurse noticed that he was wearing a military charity wristband and asked him if he had served in the forces. Once she knew this, she was able to refer him to Op Courage, the NHS mental health service for veterans. Following this, he was assessed quickly and is now getting the support he needs, particularly as Op Courage staff have an understanding of the unique challenges that can be faced by veterans. In addition to this support, Ryan has also been connected with his local armed forces and veterans breakfast club and is feeling more positive about his future. Sarah's husband has just left the forces after serving a full career. He's looking for jobs at the moment, but he is starting to feel overwhelmed as he navigates the civilian jobs market to find roles that match his skills and expectations. Sarah is worried that her husband's mental health may suffer if he continues to be so hard on himself. He puts a lot of pressure on himself to succeed, and this is starting to take a toll on his mental health. She is struggling to determine how best to support him, whilst also looking after her mental health in these difficult circumstances. Whilst attending a health fair, Sarah got talking to a nurse about the family's struggles, and the nurse asked whether her husband is a veteran, as she recognised some of the language Sarah was using. Once she knew this, she was able to connect Sarah with her local NHS Trust Armed Forces network, who were in turn able to refer Sarah to a military family support charity and arrange some peer support with another military spouse. This also allowed Sarah to access advice on housing and some additional veteran-focused employment support for her husband. The nurse at the health fair had undertaken armed forces awareness training, and their understanding of military language had meant she was able to confidently ask if Sarah's husband had served. Sarah was able to access support that she had previously not known about. Asking this question can help understand a situation better and help members of the armed forces community access and receive the support they need, and upholds the NHS commitment of the Armed Forces Covenant. To get in touch with your Veteran Aware Trust, email us or visit our website so that we can support our armed forces community to get the help they need.
Distinguished guests, ladies and gentlemen, good morning and welcome to this morning's Veterans Current Healthcare Alliance annual National Best Practice event, which is being held a week after the Invictus Games, where 21 nations took part, including Ukraine, I might add, 500 odd competitors and indeed 1,000 odd family members from across the globe supporting the armed forces community. Long may that continue. Thank you so much for taking the time to join us today, and all the more remarkable given the continued pressures on everyone probably sat in this room. For those of you who don't know me, my name is Guy Benson. I spent 40 years in the military as both a soldier and an officer. The NHS is my first real job, and I feel very privileged to be part of that team. I think what I would say about the VCHA, I am actually the team leader of the Veterans Current Healthcare Alliance, and I am led by two people really. Firstly by Professor Tim Briggs, who is in the RNOH and has got a huge job, but obviously I'm conscious that I'm commissioned by Kate Davis, who provides us funding to deliver this outstanding programme. May it long continue, Kate. Before we get proceedings moving, a couple of housekeeping rules. There were 200 people who booked to join. I think we're probably about 150 at the moment, but there's been a few issues with travel and the like. And we should hopefully have about 130 online, which is good. Can I ask people to switch their mobiles to Rumble, please? And virtual users to please mute and turn your cameras off. Keep chat to an absolute minimum, and questions should be placed in the chat box, and they'll be answered by a team that I've got in the back with Anna-Marie and David Wood. If we don't get through all the questions, we will follow up within 5 working days to get that closed down, and the event will actually be recorded, so people will be able to use it for posterity. There is an event survey, and there's QR codes in your programme, so please do take the time to fill that out in the next couple of days. Fire, no planned test of the alarms, so if the alarms do sound it is a real fire. You will be directed from here by staff from the Barbican, so please don't panic. Toilets, there's 2 sets. There's one sort of, if you turn left out the door in like a conference room type thing, or you go downstairs and there's loos down there as well. Feeding, anyone who's got any allergies, can I please ask you just make yourself known to the staff when we do lunch. And finally, social media, can everyone please use hashtag NHS Veteran Aware? That would be really appreciated, please. It is really good to see such a strong attendance from so many people who share a passion for our armed forces community. And I know there are many old friends sat in front of me who are participating in today's event, who have been supporters of the armed forces for many years, and it is a real pleasure to welcome you here today. In terms of aim of the event, it's a common aim. It's to celebrate what the VCHA and indeed others sat in front of me have achieved to date, continue to develop and share and drive the implementation of best practice, demonstrate impact, progress, critical to our programme going forward. And I want to adopt the whole force approach, and more of that a little bit later. And obviously what I want to be able to do, what we all need to do, is improve our armed force community healthcare, whilst at the same time raising standards for all, and that is really critical. So stuff we're doing now will help everyone in NHS England and beyond. I mentioned the whole force. Sorry, that's a very busy slide. This is a military term, and I just wanted to expand on what it means to me and Professor Briggs. Firstly, the whole force approach should be implemented based on deeper, more effective integration by all partners. And we are all partners. We are all in this together. There must be more teamwork and trust between primary care, secondary care, health and social care, the MOD, and indeed the military third sector, who are represented here today. And the strategic partnership between the NHS and MOD has never been stronger, thanks to Kate, probably. In the whole force, and especially where exceptionally high quality healthcare outcomes are expected, there is no place for just transactional relationships. There must be a fully understood, agreed and approved set of requirements provided which leave no room for doubt that they will lead to the desired outcome for all our armed force community in healthcare settings. Bit of a mouthful, sorry. Our armed force community must have complete confidence in healthcare providers, and this requires a partnership model supported by connected, innovative and flexible service. It's worth noting that we have a broad range of participants from the whole force, as I'm calling it, and hopefully I'll cover both left and right of arcs in terms of overviews, updates, demonstrating impact progress, and touch on what we are doing to ensure programme sustainability, which will continue to directly support our armed forces in terms of healthcare. It is worth remembering over the last couple of years, our armed forces have stepped forward to support our nation through the COVID-19 pandemic, from constructing NHS Nightingale hospitals, delivering testing in our communities. Indeed, some of our veterans have been at the heart of the military effort in many communities, and they still do that today. As a result of this, the Armed Forces Covenant, and indeed the Veterans Current Healthcare Alliance, has never been more vital. Partners across the UK in the public, private and charitable sectors have continued to support those who serve or who have served and their families. As we know, there is already excellent work going on across England and indeed the devolved nations, and we continue to build strong relationships between local authorities, the NHS, independents, social care, the MOD, military charities, ICSs, all seen as critical to healthcare improvement. But as we will hear today, through further partnerships and collaboration and coordination, so much more is possible. And today offers a chance to continue to make a substantial difference for the military community and a real difference to those with the greatest needs. This is our opportunity to celebrate and improve our delivery of the Armed Forces Covenant alongside the VCHA and indeed other programmes within the NHS. And this will make a positive contribution to the lives of service people, our reservists, our veterans and their families who continue to support us and our nation so selflessly. In terms of programme, a really ambitious programme, lot packed in. The first thing I want to say is speakers, you've got 15 minutes, and I've got a little helper down here who will tell you at the 10-minute point and then the 2-minute point. So please take that in for what it's worth. The key, I suppose, really is all these work streams are inextricably linked and indeed connected through the Armed Forces Forward View by Kate's team and the 9 commitments. And everything people are doing today links absolutely into the 9 commitments to the Armed Forces, and that is really important. So Kate will be up first to do the big picture in terms of Armed Forces Healthcare. We'll then get some programme overviews and updates. And really that's about quality improvement, continuous improvement, which is obviously critical. And that will be the whole healthcare pipeline. And I think it's the first time in a room we've had probably everyone sat together leading on this pipeline. So the touch point for every veteran or member of the military community, there will be an accreditation process. That's really important. The operations, which are generally on point, so that will be Op Restore, Op Courage, which are again critical and at the front line of supporting this campaign. Minister Mercer will join us at 12 o'clock remotely, so he'll have a couple of things to say. And we've got some key leaders and influencers from the military third sector as well, so really important. We're going to demonstrate impact and progress reports from some of the trusts at the front line, which is really important. And it's great to see the ambulance services here as well, because they are part of that healthcare pipeline. And finally, one of the key areas that probably needs gripping is the identification of the armed forces, and that is really critical going forward. And in fact, the short video you saw there was produced by Jordana down there, who did a fantastic job. Thank you very much for that, Jordana. So data critical, both quantitative and qualitative, and we've got some key players in the room who will give us a bit of feel for what's going on there. But, you know, this data will improve and benefit patient healthcare providers and indeed local communities, so really important. And finally, as a closing address, Colonel David Richmond, who just sat there, who will give us his wide words and direction and guidance. David. I'd like to now hand you over to our first speaker. However, before I do that, I just wanted to introduce Kate. Kate is the National Director for Healthcare Services across England for armed forces serving personnel, veterans and their families. She also leads on sexual assault referral centres, commonly known as SARCs, and prisons, immigration removal centres and secure children's homes and training centres. Her national role is to assure high quality, consistent and sustained services with a strong focus on health inequalities and outcomes for our patients and their families. Kate's commitment to the lived experience, co-production and addressing health inequalities has led her to being awarded an OBE in 2009 for her services with disadvantaged communities and indeed a CBE in 2018 for her work to improve services for some of the most vulnerable groups in our society. Kate, over to you.
Wow, what an introduction. I sit there and think, my gosh, did I do all that? And yeah, I've got a 93-year-old mum who's at home quite poorly. And I would love her to have heard that, if I'm honest with you, because I'm not sure she knows actually either how much. And I think the reason I say that, because all of this that guys over kind of introduced today is about people, isn't it? It's about the people that are close to us. It's about the people that we've worked with. It's about the people that we know as part of our partnerships. And I'm here to give the bigger and strategic context. I'm very happy to do that. But I think underneath all of that, and because of all of that, is we do it because there's someone we know or there's someone that absolutely is still struggling. And I think that's the bit that we have to keep in mind, Guy, as we go forward with this as well. So thank you. Okay, right then. So I've got quite a few slides. I'm not going to dwell on all of them. I'm going to be quite general as well, because I think what I want to do is be able to have those slides to be shared, Guy, and used. And I know that also already the Armed Forces NHS Public and Patient Voice Group has already had these slides and shared with them. And the co-production of all of this has been absolutely crucial. So yeah, I'm the Director in NHS England for Commissioning Armed Forces Healthcare. And I think let's just kind of remember how far we've come. I know it's absolutely, I'm going to call him out because I will do, but it was delightful to see Keith Willett in the audience today. And it reminds me how much NHS England in 2013 really didn't have a understanding or a grip necessarily to do with how we could look at strategically the growth and the quality of the patient care of the armed forces community. And there are many, many individuals in this room that have absolutely made it matter. And they're all on the programme today. But where we are now is working with that as part of the new NHS England, as part of the integrated care boards. Now, I know when I was in Birmingham, I had a sort of similar slide, Tim, and I was just sort of having a chunter about that earlier. But it's a thing now. Back in July 2022, we had the new legislation. We've got 42 integrated care boards. It's about focusing on population health. The Armed Forces Covenant is really crucial as part of that. Many thanks to our Department of Health colleagues and Joe, who's here today, who worked tirelessly for many years in the background, ensuring that we had the legislation and we had the understanding and the grip around what that means within the new population-based healthcare. But I'm also really pleased that NHS England have enabled the National Healthcare System and the NHS England overview to maintain a very strong national focus on the armed forces community. So the first 4 bullet points you will have seen before, if you've certainly seen me talk or others speak, which is the key and core kind of objectives of those integrated care boards. And the health inequalities element, the whole element that have been driving and improving those outcomes, is where we keep focusing on what does that mean in Bristol for our armed forces community compared to what does that mean up in Blackpool and so on and so forth. And that's, I think, the core of the reality of the broader context. Where we are as an NHS is in, a pretty pressured place. We've been, I think, kind of not on the front page of one news report to another on a daily basis for many, many years, from COVID to COVID recovery to all of the work that we're doing now as part of, obviously, waiting times, to elective care, to primary care, to mental health. And also, of course, you know, today is a day where we're focusing also on delivering that with probably one of the biggest and sustained parts of industrial action as well. So it is really important to come back with all of that going on to the focus of what our business planning elements are. Again, I'm not here to go through those in detail, but I wanted to share with you, as Guy and Tim had asked me to, the bigger context of what this means for driving what is seeing 1.5 million patients a day within the NHS, 1.3 million staff working in the NHS and growing and needing to grow, and what that means for, you know, 160 billion, you know, public sector body. And you know, I will echo that it's absolutely now about quality and sustainability within the armed forces community, within the NHS, the third sector, our relationships with the MOD, Defence Medical Services, the Office for Veterans Affairs. We have driven lots of change. We have driven lots of NHS-focused care and support as patients for the armed forces community, including reservists, including people that are serving their families and carers, and so also veterans, and a bigger focus on health and inequalities. Fantastic. There is still more to do. But actually, what's 24-25 about? It's about quality. It's about slowing down a little bit, actually. It's about sustainability. And it's also about saying targets are really key. And I know Minister Mercer will drive those hard. I'd expect him to. But I also want to have targets that stick. And I also want people to have the longevity of those targets as well. So I think that's something that, you know, is absolutely core. But we share the load. We share the load on doing this together. And this is probably, I think, a slide that's kind of gone through the whole of NHS England, sort of armed forces community development, is that we really important to say where and how do we work across the MOD, how do we work across with primary care, with community mental health, with secondary care and others. And it's really important that we don't lose that baton as part of people and patients are concerned, or lose that baton actually, I will also say is in the bigger context to do with funding and flows. And that's really important in the investment that we're giving this work within NHS England. So just moving on swiftly, there is always a plan, and the long-term plan has and still continues to be really strong for the NHS world of support, care and consistency across England, as well as obviously that partnership work with devolved administrations. But it continues to have in its refresh a really strong core all the way through as part of our covenant, but also our requirements as far as armed forces health and commitments. Guy's already mentioned it, so I'm not going to mention it again, but I think, you know, it is and it has been incredibly important to have publications and policies, both the Armed Forces Forward View, but also the work that we're doing constantly on upgrading and looking at what that means when we're looking at the elective care point at the moment, mental health, with a new Mental Health Act or bill going through, hopefully, and other areas that we're doing. So this is really important that we get this in a policy and a programme area of work, because it is about people, but it's also about different people coming in and not having to reinvent the wheel. That's also part of the future. So, I mean, I think the last kind of slip through of my slides is really just to sort of talk about the outcomes and the improvements for community. And our patient experience is key to everything. You know, there isn't a day that goes by, there isn't a week that goes by when we haven't someone that gets in touch to say that was really good, or actually could you improve that, or I'd like to let you know how that worked for me when I was kind of serving and coming through one part of the community, but how that maybe didn't work quite the same when I was a veteran and coming through another part of the community. And that constant improvement angle, as well as data and evidence, is key to the way that we are personalising it, but also sharing that insight and best practice, and also challenges around effectiveness and efficiency. So I was pleased to see this one on the bottom of your big slide a minute ago, but because this is a fairly new but important kind of overview around the developments. We said for some time, and I think my team will laugh at me because I've had a scrap of piece of paper with 4 squares on it and chucking it at the team screen for people for quite some time now. driving the connection between our healthcare for our armed forces community. So we've always had that concept and that requirement to look at what that means for mental health with Courage. Look at what that means for the whole physical healthcare and complex pathway and trauma, physical trauma with Restore. What that means around some areas where risk and patient requirement needs a different kind of angle around where people hit what service when. That's what OpNova is for men and women and families who are affected by veterans in the criminal justice system. And Op Community, which is a name that's been chosen by families and carers to support that need of connection locally, but also as part of that framework, particularly with the ICBs. Okay, there are some numbers on there, and there are other people that are going to focus on these areas coming forward on the agenda, so I'll let them talk those through, because I'm going to pick them up now, just on a couple of them. It is really important to have those targets, and it is really important to know what we're doing for the millions of people that are part of our Veterans, Armed Forces, Reservists and families and communities. And thank you. You are the first to hear from an early morning email this morning and I know Dr. Jonathan Leach is here, and he'll talk much more on Emily about that than I will. But we are now up to, this morning, 81% of primary care clinical networks being covered as part of the RCGP accreditation area. We're driving hard for improvement. We're driving hard, I know, thank you very much, with the way over 75% for VCHA. But it's actually about not leaving anyone behind, isn't it? And we don't want someone not to have the same understanding, consistency or quality in many of these areas. So I think the numbers do matter, but it's actually also aiming to, as I say, sustain and also support staff and workforce. And many of the staff and workforce, of course, have been themselves within the military community, but many in the NHS haven't, the majority. And it's really important, like people like me, who haven't had that military background, are the ones that sometimes need convincing, actually, or educating, or supporting, or feeling, oh, is this one, quite for me, or how do I come forward? We don't say that as an NHS personnel, whether we're clinical or professionally commissioning, when we're talking about looking at cancer, or when we're talking about a patient group who may be particularly there also within mental health. It is really, really important that you, as the community who knows the score, consistently helps to support the NHS's understanding of what this means to be collectively within the armed forces community, and hence the partners within the charitable sector and also within the lived experience and clinical community. So I guess this kind of is my summary. I know I've just been given my 5-minute warning. I'm probably on about 3 now. This is one of the feedbacks, in fact, Tim, we got in Birmingham, we've had in a few other events, which is about that consistent visual approach. We have to continually support and ensure that services are responding as early as possible, that people know that it's there for them. What does that mean for women? What does that mean for black and minority communities? I'm standing here today since the last time of the conference in Birmingham with obviously the ban and the report as part of LGBT communities within the armed forces. A very moving and a very important moment. What does that mean around sexual assault? And as someone who does lead the policy for domestic violence and sexual assault within the NHS, and there's been a lot of that at the moment in different parts of the community and different people. And I have people that are personally affected that within my family, as well as also within our immediate sort of professional groups. It is really important that we stand up to the needs of supporting what that means within our professional and personal lives. So we underpin this more and more with a comprehensive communication and visual strategy. And I would say that the patient voice and the lived experience has probably been the most influential in getting that right. And we've not always got it right, and we've had to go back to go forward. And we're about to have a new Courage campaign. We're about to look at how the National Veterans Digital Share Care Record, and I always have to read that one because I never remember it, is really standardised as part of NHS digital work and data, but how it works across, and thanks to Nick Pope and many in Cobsio who have been supporting that as well. And it's also about supporting that whole Armed Forces Veteran Healthcare Alliance, because without that, you don't bring people with you. So, thank you very much. I think it's really important that we continue to share and support. We continue to put it in the bigger context as well as looking at the narrative as we go forward. So I'd just like to conclude. I'm doing all right, I'll tell you. Yeah, thank you very much. I think what is important is, and I was doing this in another area of work only recently, is that we look at pace. Pace isn't just about doing it quickly. Pace is also doing that together, multi-professional, multidisciplinary, and also sometimes slowing down to reflect and look back. The Armed Forces community has always done it with passion. I love the word passion. I'm often say, oh, Kate Davies is really passionate. Well, yeah, I am, but I'm also pretty professional as well. It's really important to bring those together. Because what we are doing is we're doing this with the other elements of this, which is purpose, patience at the middle, and we're doing it in partnership. So thank you.
Great. Thank you very much, Kate. And it's always really useful to have the top of the head shed giving her vision. And Kate, thank you very much from all the Armed Forces community for what you do. You work long hours and you've got a pretty tough portfolio. I think now what I really want to do is go to the next speaker, which is Emily, Dr. Emily Brooks. Hang on a minute, Emily. Wait for it. Over the next hour or so, I'm going to really take you through that healthcare pipeline, in effect from cradle to grave, which I know is not a particularly nice term. But I'd like to introduce you to our first clinician, Dr. Emily Brooks, who is the RCGP Veterans Clinical Champion. And Emily started her medical career in the Army, completing her GP training and spending 11 years working with the infantry both in the UK and abroad, including Cyprus, Germany, Malawi, Kenya and Belize, as well as spending over a year as a doctor to the infantry battle groups in Helmand province, Afghanistan. Whilst in the Army developing an interest in MSK medicine, she completed an MSc in sports and exercise medicine and undertook research with the Institute of Naval Medicine into MSK injuries in deployed infantry soldiers. She also worked with soldiers with severe life-threatening injuries and mental health problems, particularly post-deployment to Iraq and Afghanistan. In 2011, Emily transferred to the Royal Air Force, working as a GP, trainer and appraiser, trained as an aircrew medical examiner, and established the first 5 MOD support network in conjunction with the RCGP. Retiring as a wing commander in 2017, Emily has since worked as a civilian GP for the MOD and for the NHS. More recently, she led a small specialist team with UKHSA as part of a response to the COVID pandemic. Emily has family members who are veterans and so has personal experience of being a veteran, being a family of a veteran, as well as looking after military personnel and their families. Emily, over to you.
So good morning. Thank you for inviting me to speak today. You've already had my introduction, so stolen my first bit. So I'm actually one of 2 clinical champions. So Brigadier retired Robin Simpson is the other clinical champion as well, which some of you may already know. I joined the team at the Royal College working on this project last year. So in terms of the GP Veteran Friendly Accreditation Programme, I'll just put some stats up there just to sort of update really as to how we're doing with that. So it's slowly progressing, we're gaining momentum. Those figures are actually out of date. So as Kate said, there's 81% now of PCNs that have at least one practice accredited, which is really great news. And 48% of ICBs have have over 40% of practices accredited. So for those of you who like a picture, I thought I'd put a picture up. So as you can see, it's sort of, steadily increasing. You'll notice there's particular points where there's spikes, and actually Remembrance Sunday is always a really good time in terms of raising awareness of the project. And last year we worked with Evergreen, a PR company, and we had a really good uptake there with, I think, about another 172 accreditations during that time. So we're really positive and hoping that we're going to have a really good leap in progress again this November. So I was just going to talk through really sort of how we're going about engaging primary care practices and encouraging them to sign up to the programme. What we've realised is just there isn't a one-size-fits-all in how we can get that engagement from practices. So we've tried engaging through ICBs, PCNs, individual practices, presenting at primary care conferences, and also some media campaigns which have been really successful. Since about February, March this year, we've been working with the clinical support unit, and they've been trying to assist us in gaining more traction at sort of ICB PCN level. And so we've been supporting them with materials to sort of get the right message across, and also providing presentations to practices, ICBs, PCNs, primary care support networks, as and when required to really encourage practices to engage. As I said, the Remembrance Day campaign last year was really successful, and we're hoping for the same to occur again. Also doing podcasts and webinars involving other colleagues as well, such as social prescribers. We've just done a webinar with social prescribers, and there was a pilot using of Armed Forces community specialist social prescribers. So we've done a webinar so we can educate GPs about that sort of resource that they hopefully have access to. And then another recent podcast that we've just done is with Restore, and really kind of explaining things at the sort of for GPs. So for a GP sitting in their surgery, what do they need to know? You know, who is it they can refer? How do they refer? How is that going to benefit their patients? The challenges that have really come about in terms of getting practices to engage includes a lack of understanding of what it involves. Primary care is incredibly busy at the moment, as is the whole NHS. And I think some practices have maybe been put off thinking it's a sort of an extra big workload. So what we're trying to do is just explain to practices that we're here really to support them, to support their veterans, and actually to make life easier for their patients as well as the staff too. So I just want to talk a little bit about the future, really. So as I say, hopefully the Remembrance Day campaign this year will bring about a lot more interest in the project. And in response really to the pressures on primary care, what we're doing is we're rewriting the toolkit for newly accredited practices just to make it really easy for them to implement the toolkit and other aspects, and audit the practice to see how many veterans they have and look at ways that they can increase the number of coded veterans. And just making the initial CPD package more in about an hour, so that's something that practices can do in their practice CPD time. Other areas which may be useful for us to look at, Restore, we know about half of patients being referred aren't from veteran-friendly accredited practices, so that's an area that we potentially could look at with our colleagues as to why that might be. But I think it's encouraging in some ways that even though practices aren't accredited, patients are being referred into Restore, which means that essentially veterans' healthcare is improving through knowledge of the referral pathways. The other areas that we could look at working with our colleagues, care homes. If care homes are now going to be accredited, all care homes have a GP practice. Are the care homes asking their GP practice if they're accredited, and if not, encouraging them to maybe think about becoming accredited? The other thing is patients, so inpatients, when they get discharged from hospital, there's a discharge letter. If they've been identified as being a veteran in hospital, is that on the discharge letter? So GPs can see that and add the appropriate read code for that patient. And other areas as well, I think Jonathan will probably come on to speak to about, but with Op Courage, for example, we know there's certain key points where veterans may struggle more with their mental health. For example, the withdrawal from Afghanistan was quite triggering for a lot of people. So using the practice accreditation network really to message out to veterans, making them aware that there's Op Courage and the support is there for them, and encouraging them to come forward and get the support that's there for them. We had some really interesting and good research from Chester University a couple of years ago, which was really supportive of the programme. It was mainly focused on the evidence of the impact for practices. So 99% of practices who were accredited said they would encourage other practices to do so. They felt that they were more aware of the needs of veterans, they're more likely to identify who their veterans were, and they felt that they were able to refer patients to specific NHS referral pathways. So that was all really positive. But we're thinking about maybe research from the veterans' point of view and the impact for individual veterans. So in summary, we're moving in the right direction, and we're just really keen to continue to work with all our other colleagues, and we're in this together. Thank you.
Great, thanks very much, Emily. And Andy Cole, Chief Exec of, is just over there on care homes along with Catherine, so please connect during the day. Right, I'm going to hand you over to the next clinician, to Jonathan Leach, Dr. Jonathan Leach, who is a GP in Bromsgrove, Worcestershire. And Jonathan originally pursued a military career for 25 years and worked around the world in the army, being promoted to the rank of colonel in 2002. Post comprised of clinical, managerial and academic roles, including Professor of General Practice and the Director of GP Education, as well as providing medical support for UK operations overseas in both clinical and command capacities. Since returning to the NHS in 2008, he has had senior executive positions, including Medical Director and Director of Primary Care for Worcestershire and Associate Medical Director for NHS England. In addition to clinical work in Bromsgrove, Jonathan is the NHS England Associate Medical Director for Armed Forces and Veteran Health, and thus advises NHS England on the NHS care of service personnel, their families and veterans. In this role, he has been instrumental in the design and delivery of new models of care for veterans, and especially in the field of mental health. In November 20, Jonathan was asked to be Medical Director for COVID-19 vaccination for England, a programme which has now delivered over 150 million of COVID-19 vaccine. Jonathan stepped down from his role in September 22 to concentrate more on his medical responsibilities. Jonathan was awarded the OBE for service to general practice in the 2020 New Year's Honour List. Jonathan, over to you.
Yeah, thanks very much. A bit like Kate, I don't think my mother would recognise that either. So I'm very much a clinical doctor. It's great to be here. You know, I was seeing patients yesterday, and actually quite a few of my patients, we're a veteran accredited practice, just to pick up on what Emily's saying, actually 3 of the patients I saw yesterday were military veterans. But also I think that some of the wider aspects of what we're trying to do in the NHS more strategically are actually for our general patients. And I was reflecting with some of my colleagues that one of the patients I was helping yesterday was a retired police officer. Now, this retired police officer had seen some terrible things, as often police officers do. You know, he'd been to incidents where somebody had unfortunately put a ligature around their neck and died. So actually some of the skills which we are using and we're building within the NHS, yes, it's for the military community, but actually we very much as an NHS England team, it is for the broader use of our general population. And I think that's one of the key things. So I'm going to talk about Op Courage, but actually the tentacles go wider, because actually what we're doing is that we're driving many of the changes, actually not just within for the military community, but also for the wider. And actually that police officer yesterday, or another of my patients yesterday, who is a woman who had suffered terrible abuse and sexual abuse by her husband, she has PTSD, and actually she wakes up in the middle of the night with her nightmare of her ex with his hands around her neck. So actually these skills which we're giving to the NHS more generally actually are really important. And I think it's not part of my talk, but actually that's actually a subtext of all the things that we're trying to do. And actually it links across to what Kate was saying, and it links across very much to what Emily said. So what I'm going to do is just run you through some of the Op Courage things. So the formal title is the Veteran Mental Health and Not Wellbeing Service. It is broader than just health, and in fact that's a really important thing. I come very much from an aspect of the social determinants of health, and when I describe the model, and many of you will be aware of the model of Op Courage, but actually some of these sort of wider determinants of health are really important. Just look at clinical need for a second. I'm going to cover serving personnel, and then I'm going to cover veterans. The interesting thing is actually the changing nature of, these are the medical discharge figures. Now, traditionally, particularly as an army doctor, and I'll defer to Emily with her MSK experience, we would have said traditionally the biggest reason for medical discharge from the military was due to musculoskeletal injuries. Actually, more recently, and we don't understand why, it might be something due to data, it might be due to changes in medical board procedures. Actually, the last 2 years, for the Air Force and for the Army, the biggest reason for medical discharge has been mental health. And actually, that's quite a change. And I think that's a reflection of perhaps people coming forward more. It also may be just a reflection of where society is. But it's a really important thing. And actually, one of the things we do, and I'll come back to the clinical model, is that we work with MOD all the time. I was on a call yesterday with the Defence Consultant Advisor in Psychiatry to the MOD. That was Surgeon Captain Darren Minshaw. So we have very, very close links with the Ministry of Defence. So it's an interesting thing in terms of the needs of the current serving personnel and what that is going to mean as inevitably people become veterans. So the other thing about veterans is there are a huge number of myths about them. Many of you will be aware that virtually all of them are wrong, actually. We're all mad, bad, sad in a paper bag. We're all homeless. Actually, the vast majority of veterans are really great people. And actually, one of the talks I give is to business. And so, for example, I was recently doing a presentation to Kia. Kia is a construction company. And actually, I was saying, look, actually, veterans are brilliant guys. They bring a work ethic. They, bring the skills and experiences. They can public speak. They know how to turn up on time. So actually, yes, you skill them up in terms of what they want to do, as a construction company. But actually, they can be really, really useful members of your workforce. And actually, that's a really important message, because actually sometimes the messages and the public here, particularly through the media, actually don't represent. And actually, one of our concerns is that sometimes those messages get in the way of people getting jobs. And that's a really important part. So if you look at Barclays, if you look at BT Open World, Kia, actually, it's a really important thing that we can do. The Step into Health here, if you haven't been down and spoken to Irene, absolutely brilliant. Similar sort of thing. Yes, we as the NHS want clinical staff, but actually we need non-clinical staff, to actually help in terms of the running and the management and the delivery of NHS services. So in terms of the veterans themselves, the main issues, not surprisingly, are about alcohol, substance misuse, and depression and anxiety. And actually, those still remain the biggest issues. Of course, there's a big focus on post-traumatic stress disorder. What's interesting, actually, is that if you look at the combat stress data, is that we used to say it was about 14 years between somebody leaving the services and consulting with mental health services. Actually, it's a good thing that has come down, but it's still too far out at 7 years. It's a good thing because we know that responding and intervening earlier is much better. It's a bit like cancer. You know, if you can respond earlier, it's before that patient goes downtown, gets pissed, gets a criminal conviction, can't get a job, gets a marital, disharmony, breaks up, all the rest of it. So actually it's good that that's come down, but 7 years is still too long. So if we actually look at, this is King's College data, if we look at PTSD, it's about 4% in the general population. Actually, if I'm going to particularly put this in the context of other groups, it's about 25% of paramedics have PTSD, and it's about 33% of women, particularly those who've suffered sexual assault, sexual abuse, domestic abuse. So actually that's the biggest group, as I described from my lady from yesterday. So it's about 6% in the general military population. Those who have been deployed, it's higher, and particularly those who have been in warfighting roles, so it's about 17%. So it's certainly higher, but it's not as high as perhaps people would think. But, whenever I ask my patients, who do you think is the biggest? Actually, they say it's the military. Actually, it's not. And I think that's an interesting question, actually, for the wider NHS in terms of what services we deliver. Because certainly, if I'm trying to get evidence-based treatment for PTSD for my wider patient population, I can do that for my military population through Op Courage. Actually, we've still got a long way to go for the rest of the population. So it's about 17%. The other thing that we've been doing as NHS England is that we've been supporting research with the MOD through the University of Manchester. This is Professor Nav Kapoor. And what we've been able to do, or Nav has been able to do with the wider team, is to actually look at the suicide rate. Now, our view as NHS England is every suicide is avoidable. It's very clear. And we're very clear that this is a tragedy for the individual. It's a tragedy for those around them. It's particularly a tragedy for those who are loved ones. And I've spoken to many, and, some of what's gone on sometimes, it just makes your heart bleed. It really does. It's terrible. But the academic evidence is that the overall rate for suicide within the military community is not higher than the general population. But as I said, I want to caveat that these are all ones where we should be able to do better. And actually, as NHS England, we look at every single one when we know they're a veteran. But counterintuitively, those who have been deployed, actually, it's lower. Now, we've got higher PTSD rates, but we've perhaps got lower suicide rates. Now, that perhaps is because of what we describe as a healthy warrior effect. So if you are deployed, you're not downgraded. So you're in good physical health and you're good mental health, which actually is a resilience. It gives you extra resilience when you deploy. However, the group we are really worried about is young men. Who actually, those who leave the services early, actually they're the ones we worry about, and they have the higher rates. So let's just look at the clinical model. Firstly, we've done this on the back of a huge amount of research. We wanted better accessibility. We wanted better understanding. We wanted evidence-based treatments. I was on the NICE review group that looked at what evidence works or what treatments work. We wanted the social determinants of health going there, links with general practice, as Emily has described, links with Opnova, and Kate has discussed that, and the wider NHS. So the model is really very clear. And in fact, we do pick up people as they leave the services because we're very clear about that. We've had about 30,000 patients now through Op Courage. Average waiting time is, 14 days. The KPIs, Key Performance Indicator, for urgent is 5 days. And it's 10 days for routine. Now, 14 days is too long, but that's still significantly better than other areas. Now, it is deliberate. It is absolutely deliberate that it is that tight timetable. Because as I've described earlier, what we're trying to do, and when we designed this, we were all sat in Skipton House in a, inverted commas, smoke-filled room. How are we going to do this? We wanted better access. So 60% are self-referrals, referrals by their loved one, or referrals by their charity. So if you're here from a VCHA and you're a trust, you can refer. It does not need a GP referral. And that is absolutely deliberate. Yes, 10% of referrals are by GPs, and I refer. but we do not need a GP referral. It is then that that patient is assessed. When we've described this to our international comparators, for example, in Canada or Australia has a major problem with suicide of military veterans. They've got a Royal Commission. They're really interested in how we've been able to address this, particularly this open access. And you, as Kate has said, and I put here, that we're actually increasing the spend. Now, internationally, we're doing well in terms of this, but clearly we want to do better. And actually, one of the things we look at is actually, for example, when sadly a veteran has taken their life, one of the concerns we have is still the number who actually are unknown to what courage. So actually, that is a major issue. Actually, so you as VCHA, as trusts, do ask, but you can suggest that people get referred. They can self-refer, speak to their loved one. Do you know he can be referred or she can be referred? The other aspect of this is that it isn't just for combat trauma. We've been very mindful of many of the stories about sexual assault, sexual abuse, the abuse to the LGBT community. So that it's really important that people understand that it is wider. And actually, we've been working with providers so that actually they have a greater understanding and be sensitive and be able to support, for example, a service person who's been subject to sexual assault, whether or not they be male or female. So it's really important that you understand it's greater than just combat. The future, we continue to look at best practice. We look at this all the time. We interrelate with the MOD. I was with Simon Wesley and Neil Greenberg from King's earlier in the week last week. We adapt it, such as, for example, those who have been subject to sexual assault and domestic abuse. So in addition to combat, as I've said, very close links with the MOD. We want that handing over of the baton as somebody is leaving. And we're very clear about the mechanisms. So if I was still serving, as Dr. Leach, Colonel Leach, as a military doctor, I can advise my military patient that they can be seen and assessed. Third sector is key. Walking with the Wounded, many other charities in here, really important. You know, the housing charities that, for example, support Op Courage in London, they're not a military charity, but actually really important. And then, as I said, links with international partners. Numbers have given evidence to Canadian, US, and New Zealand, particularly the Five Eyes, about how we're going about delivering this based upon the evidence that we have and also the lived experience, which Kate has said, and I know Nikki Murdoch is here as the chair of our patient participation group. That has been absolutely instrumental in terms of how we design and deliver these services. So Kate put this up. There's a keeping up to date. So if you want the QR code, you can be on the list to actually get the stakeholder brief. And that's me. So I think I'm on time. How's that?
Ladies and gentlemen, I'd now like to hand you over to the Minister for Veteran Affairs, the Right Honourable Jonny Mercer, MP. As way of a background, coming from a military family, Jonny could only resist the allure of the military for so long, so he elected for the army and graduated from Sandhurst in 2002. He served from the tactical to the strategic level throughout a career across the globe, including multiple combat operations. It was Jonny's displeasure at how his cohort of military personnel and veterans were treated by the governments of the day that drove him into politics. And despite having never been voted in before, he was in October 2013. And Jonny was selected by the Conservative Party to fight his local marginal seat of Plymouth Moor View and won the seat in 2015. He was reselected in 2017 after only 2 years in the job with an almost five-fold increase in his majority. Having suffered from OCD since he was a boy, Jonny regularly refers to his own experiences to help drive through much-needed change around the stigma of mental illnesses and the paucity of esteem between mental and physical health. Jonny lives with his wife Felicity, who is actually a force of nature, who he met at school and has 2 children. So I'm hoping I can hand you over to Jonny Mercer now.
Hello, can you hear me? I hope so. David, hi. Thank you for having me this morning, and thank you for having me to speak at your conference. I'm sorry I'm not there in person. I'm sorry I'm a little bit late. We just had a cabinet meeting about the obvious. but I really wanted to join you today because I know that the NHS does extraordinary work in this space and has done extraordinary work in this space for a really, really long time. And so I kind of wanted to start by saying a couple of thank yous. Thank you to Tim for your work as the chair of the national lead of the VCHA, to Guy for your work as the national team lead. It's critically important that whilst we're designing these pathways like Op Courage, Op Restore, the IPC4V programme and all the rest of it, that the number one access point to them is often through NHS Trust or their GP. And if we're going to make this the best country in the world to be a veteran by 2028, getting these trusts and GP surgeries signed up to become veteran accredited is a kind of number one priority. And recently we're just topping 75%. So I want to say a huge thank you for that as well. I think when it comes to healthcare, what are we doing? I mean, what we've done is pull together a lot of the existing factors. I think there has been good healthcare there for veterans and mental health care veterans for a while, but there's definitely been a challenge around equity of access, understanding what the system is, having to tell your story a number of times. And from that came really Op Courage, which has proved hugely successful, £22 million programme, 19,000 referrals in its first year. And I always wonder where those individuals would have gone had we not set that up. And it just shows what you can achieve when you all sort of come together with a coherent vision about what you're trying to do, but crucially kind of turn it around from talking about what you're actually putting in to the machine and what does it feel like to be a veteran and why is it still hard to access this care? Why do you have to get passed from pillar to post? Why do you have to keep telling your story? And why are people falling through the cracks? And Op Courage, I've got to be honest, has probably been our most successful programme. I'm really proud of it. It's got enduring levels of funding and it's changed a lot of lives. I probably get a letter about Op Courage about once a week. And to be honest, that's nothing to do with me. That's all your hard work and the hard work of clinicians who really go for this every week. So a massive thank you on that. So accessibility is one part of it. The other part is innovation, that ability to respond to new data, which is really important as well. If we look at how the data sets are changing, for example, you know, on suicide, there's always been this perception around suicide. There's a huge issue around it in the UK. Obviously, across society, it remains the biggest killer of men under 44, and every one of those is a tragedy. In America, they did at one stage, they were knocking on 22 suicides a day. That is horrific. We've never been like those levels. However, monitoring the data, you know, we have seen that there is an increased risk in early service leavers now. And we want to try and understand that and make sure the appropriate programs are in place. So in terms of professionalising care, you remain less likely to take your life you serve, which I think is fantastic on the whole. But like I said, there is this cohort of early service leavers. Thank you to you for all that work, but that does kind of prove the system where we can analyze data, we can get the data in, which is the first bit, analyze it, and then react in an agile manner and put in schemes that are going to make sure we look after people properly. I do want mental and physical health to be considered in the round. So, you know, we've got Op Courage, we've got Op Restore. You know, they were there to really meet defined criteria, if you like. I don't want to meet anybody who pays to have their wheelchair serviced, who was seriously injured in Iraq or Afghanistan. That did happen again this year. They didn't need to pay for it. What was the problem? The issue was understanding the system, actually knowing where to go. And, you know, that's everything we're trying to do in this space. Op Courage, Op Restore, viewed in the round, I think is a good healthcare provision, but there's always more to do. Data is so important on this, and I'll do everything I can to fight for the resources and make sure they're there at the right time. The innovation part of things is really important. The Health Innovation Fund that we launched this year has set the right tone for encouraging integration in the veterans health space, and I thank the Armed Forces Commissioning team for all you've done in developing that those new services and continue to work across government on that to improve and innovate further. We continue to get more data from the census, right? So we managed to get the veterans question into the census for the first time last year. That gave us a whole swathe of data. We then did some, I think it was YouGov investigation of that data and had more data come in, and we're constantly doing that. Thank you for your efforts to get people to fill in those surveys and to help us collect the data to make this better for everybody. I guess what I just wanted to end on was how important the leadership piece is in this space. And in Kate Davis, we've had that over many years now, and I'm really grateful to her for that. And if you blend that with the real kind of innovative stuff from the bottom, as well as a ruthless commitment when it comes to working together in collaboration, so a ruthless focus on the veteran. What does it feel like to be a veteran? There's no point having these fantastic programs, that no one's ever heard of, and actually guys and girls who are leaving the military have no idea how to access. With collaboration, there is space for everybody, and it's a unique blend of third sector and statutory provision. We can make this the best country in the world to be a veteran. We've shown with Op Courage what we can do. I'm really excited about getting Op Restore up and running properly. Nobody in this country who's been injured in conflict should be worried about where their prosthetics are going to get serviced or where their wheelchair is going to get serviced. And we'll meet that objective as well. But thanks to H and everybody else who works in this sector. I really appreciate your work, and I'm sorry I couldn't be there today.
So I'd now really like to start on the VCHA accreditation system. And I've got a legend of a man in the NHS, Tim Briggs. Professor Tim Briggs qualified from the Royal London Hospital in 1982 with honours in surgery and a number of prizes. After his senior registrar training, he was appointed to the Royal National Orthopaedic Hospital as a consultant in 1992. His specialists interests are orthopaedic or oncology, as well as surgery to the hip and knee. He was medical director at the RNOH for 15 years, ensuring a rebuild, and was president of the British Orthopaedic Association in 2014. He was appointed as a national director for clinical quality and efficiency for the NHS in September 2015, and was asked to lead and roll out his girth methodology developed in orthopaedics across all surgical and medical specialties within the provider network and expanding now globally, Tim. Professor Briggs was made a Commander of the Most Excellent Order of British Empire in the 2018 New Year's Honours List for services to the surgical profession. In January 29, Tim was appointed as National Director for Clinical Improvement, and more recently his national portfolio has increased to include elective and operational recovery at the national level. In addition, he is the National Chair and Lead for the Veterans Healthcare Alliance, and is the Honorary Colonel of 202 Multi-Role Medical Regiment, which he's extremely proud of. Professor Briggs is an outstanding surgeon of his generation, respected by all. He cares passionately about our military community and leads from the front. Over to you, Tim.
Guy, thanks so much indeed. It's sometimes a little bit embarrassing to get all that, really, isn't it? But thank you very much indeed. And can I just say it's so great to see so many people here today. And for me and Guy and Kate, I think, and everybody else here, it's great to see how this snowball has just absolutely started to really move and motor in a very positive way with all the big players here. And we see nothing but great things going forward. As Guy said, I work in the health service, and I've worked at Stanmore, been a consultant for 31 years now, and it's gone extremely quickly. But just want to reassure you really about the NHS. Kate was talking about 1.3 million people that work in the health service, 1.5 million patients seen a day. There are 100 million outpatients a year, and there are 10 million operations through 3,000 theatres. We've got a waiting list of 7.68 million, which may seem absolutely terrible, but 80% of that is outpatients. And we're seeing in the NHS already 2 million outpatients a week. So it's 3 weeks' work. So when you chunk it up into that, you can see how we can really get this recovery sorted out. And when you look at the electives and patients that need to be treated, we're building 51 extra surgical hubs, which will be doing over 300,000 surgical procedures over the next 18 months per annum. So you can see, I think, how we can get on top of it, if we just get a level playing field and we can really drive things in a very positive way. So I think there's a lot of positivity, and I am optimistic about the future. So this brings us on to the VCHA, and I'm just going to give you a bit of introduction, if I may, about where big picture. Rehabilitation, I think, is critical, how we're widening the scope, and then our campaign plan, because we use our armed forces terms, and then a summary. So it all goes back to this, and about the Armed Forces Covenant and what we see in our armed forces, and then what do we owe them in return, about the moral obligation for those who serve or indeed have served. And I think that is really important. When you look at the numbers around the country in England, we've got about 1.7 million veterans, there are 3,000 family members, we see about 15,000 leavers a year. In addition to the regulars, we've got 131,000, almost 27,000 reservists, and don't forget our almost 20,000 Cadet Force volunteers. Kate has already shown these two documents, but they're critical. How, through the 9 commitments, work in partnership to commission safe, high-quality care for serving, and then go to commitment 3, how we make sure the transition's right down to commitment 9, which is driving research and innovation. And for that, we need data. So that is going to be critical as we drive things. So what's the aims that we set out to do and in terms of the Covenant Healthcare Alliance? Well, we want to share and drive best practice, just like we do in the NHS, that will improve armed forces veterans' care by also raising standards across the NHS for all users. Because remember, veterans are also NHS patients. And so we know that if we get it right for veterans, improve that, we can cascade that across into the NHS. And actually this all came from the GIRF programme, which is now really the QI methodology, I would say, in the NHS across 42 specialties, to the Shavas report. And we published that in 2014. And we named it after Noel Shavas, that many here will know about. But if you don't, look him up and look up his 2 citations for his 2 VCs that he won in 1916 and in 1917. What he did for his men in the most appalling circumstances was inspirational, and it is still inspirational to me. So much so that when my wife took me on a battlefield tour, that I wanted to go to the cemetery where he was buried in Branderhoek, where there are only 70 men buried in that cemetery. And we went on the most appalling day, rain, cold, miserable. The most amazing thing that left me that day was the number of fresh flowers at his gravestone was absolutely phenomenal. And that really left an impression on me and has today, and this is one of the things that drives where we are. So what we've got now, Kate was talking about the trust that we've got involved in this. It's not an easy thing they have to do. There are 8 standards that we expect. And for me, it's all about getting the trust to invest in this, getting to the dyad, the clinical groups. We have a clinician and a managerial dyad. They understand what the Armed Force Covenant is all about. They identify veterans, and that's going to be critical as we use the information to make sure we're delivering what we say we're doing on the tin. And then what we do in terms of establishing appropriate nearby veteran services, how we get them into the 3rd sector, and awareness. And we basically want to make sure that they also support the UK Armed Forces as an employer. So that is what we want as a basis. It's reviewed by a national panel of experts, including Nikki Murdoch. Where are you, Nikki? And she's absolutely critical for this. And believe me, she holds feet to the fire. Let me tell you, you can't get anything past Nikki. And then what we do afterwards, we have a 1-year review, but there's a 3-year re-accreditation process. And if we're not delivering, then we will take that veteran-aware tick, if you like, away from the trust. So it's not a one-way street. We want to continue to deliver, continue to improve, and continue to deliver for our veterans. So the very good news for me is that if you look at the bottom there, we've got 76% of trusts that are now accredited. There is now not a single trust in the country that has not engaged. The rest, 24 and 26, are going through phase 1 and phase 2, getting ready to submit their accreditation process for us and Nikki to review to make sure they've passed muster. And I want to congratulate really the Southwest, which are all now 100% accredited, and there's 17% of the veteran population in that part of the world. In London, we've been a little slower, but we are now beginning to catch up. And you can see that we have a smaller number of veterans in London, but it's very important to me, with all the support we got from the armed forces during COVID, that actually we all do our bit, including the trusts in London. So we are seeing a significant improvement. Now, what's crucial for this, and crucial to be able to demonstrate to Kate, for instance, that the money she's investing in our team is well spent, is, well, are we delivering? Are we making a difference? And it goes back to really the other programme, the GIRF programme, that is all about clinically led, using data to drive change and then demonstrate it. And now we've got a pilot site of 6 where we're starting to collect that data, another 2 that will not be far behind. And once we've got that, that is going to provide the blueprint to go nationally. And we will expect trusts to provide that data. So what are we going to collect? So we're going to do quantitative data and obviously qualitative, because it's great having the quantitative data, but do we know that what we're doing is improving outcomes, improving the condition for the person or the patient that goes through that system? And that, for me, is going to be really critical. And if you said to me, is there a trust in the country that I think is doing it really well at the moment, I'd say Swindon, the Great Western. I think they have already collected a great data set showing the number of veterans that they see, the families that go there, and I think they've set the benchmark, and Bernadette's leading on this for us, and I think they were going to, if we get that information, it's going to be a game changer. So I think that's really, really critical. The other part of the piece we're looking at is rehabilitation, and really this came from, again, working at the RNOH, where we have an extremely good rehabilitation system process for the complex patients that we treat. But when I was in full-time clinical practice, I was often seeing veterans who were coming to us who had fallen off and fallen into no man's land, if I may say, had come out of Headley Court where they'd been treated really, really well, and then they just couldn't access any service. Now, I know things have improved, but rehabilitation across the NHS is sporadic, is not fantastic, and I think it's really, really important to the improvement, well-being and rehabilitation of our patients. And I know, again, that if we get it right for our veterans, then we will see better improvements across the NHS. So we're going to have a therapies champion to go with our dyad. We'll make it a triad across all NHS trusts. We're going to create a pilot with best practice models for veterans and rehab. And what we want is staff training. And clearly, what we're also going to need is feedback. So like everything, the best way to do that is starting a pilot. And we've got these individual hospitals here who are part of that. And we will see how we're doing at the end of March, collect data. And the idea is to make it part of our accreditation process once we know what we can really deliver at these 4 sites. So we're extending the scope, if you like, into independent providers. If you look at the numbers there on the right, the numbers of those individual providers are huge. Care homes, look at the numbers there, and hospice, we're going to hear about care homes and how we're joined up with Royal Star and Garter. But there is real opportunity here so we get a completely holistic approach. As our veteran population ages, they live longer, and we need to make sure we look after them. Now, this wouldn't be possible without the team, and I think when we appointed Guy, it was an inspirational appointment. The rest of the team is fantastic, a mixture of veterans and non-veterans who deliver day in, day out, despite all the operational pressures that are on all trusts in the NHS. So this is our campaign plan, not quite like a map, but you can see where we are. And at the bottom, I've got in red the operational pressures. You know, we've got COVID, we've got flu, we've got UEC pressures, we've got the industrial action at the moment, all pressure points that actually the team overcome. And I'm really confident that we will have all trusts accredited by March next year. So in summary, 76% of English trusts are now veteran aware, which is fantastic. We've got the best practice seminar today, and just seeing the number of people is fantastic. Rehab integration and the pilot, I think, is going to be a game changer when we see the results of that. and we'll have all trusts accredited by March 24. The buddying system development with the Royal Star and Garter, the Royal British Legion, us, for social care, and obviously clearly widening scope. So I think the VCHA brings everything together. The whole pathway for patient links in with Op Courage, Op Restore, and Op Community. So if we can get this all wrapped around and all together, I think then the benefit for all our veterans is going to be fantastic, and we'll all see the real results of that. So thank you very much.
So March 24 then, Tim. Thank you. Thank you very much, Tim, for your drive and inspirational leadership and leading from the front and putting me under a lot of pressure. I'd now like to hand you over to the Royal Star and Garter. And we've got the Chief Exec, Andy Cole. He's Chief Exec of one of the country's largest veteran charities, which provides care to veterans and their partners who are living with disability or dementia. And Royal Star and Garter operate 3 highly rated care homes in England, all of which are now accredited as veteran aware. Andy was previously Chief Exec of the National Premature Baby charity Bliss, championing improvements in maternity and specialist neonatal services across the UK, receiving an OBE in 2014. Andy is also the chair of the National Care Forum and the deputy chair of Buckinghamshire New University, which offers high education programmes in nursing and social care. Andy, the floor is yours.
Thanks, Guy. It's equally embarrassing as everyone else's introduction. What isn't on my list is about 30 years ago, my first job was in level -2 in this building. So it's a lovely career arc that I've been allowed up to see sunlight at level 3 and level 4. Never accept a job in a basement. I'm here today with my colleagues, Catherine and Fran, who are over there, and if we get a chance to talk in breaks or lunchtime, then please take up that opportunity. This time last year, some of you have already said, I was here collecting a very large VCHA accreditation plaque with my home manager in Solihull, and we were the first care home in the country to be accredited. And having a sort of Remington Razors moment, we thought this was so good a programme that we needed to talk to Guy and to Tim to see whether actually there was something we could do to expand the programme. For care homes, as Tim has already said, there are 15,000 care homes in the country. That's a lot. We were delighted to be supported by Guy and by special shout out to Tony as well, who took us through our accreditation programme, but we kept bumping into lots of NHS language. Patients. We never talk about patients, we talk about residents. We don't talk about moving people out of hospital. We talk about keeping in the home in which people live. So we kept hitting these slight sort of anomalies in process and thought, based on language and on scale as well, that it was important that we put together a flavour of a new scheme that would cover care homes. The other issue, of course, was actually the VCHA technically didn't cover care homes. An interesting anomaly. And for those who know me in the room, I spend my life saying Department of Health and Social Care on a regular basis. So it's lovely to be able to be partnering with VCHA and the Royal British Legion on this programme. Try and get this to work. Right, so this is a picture of one of our residents. She lives with dementia. She's in her late 90s now, and she herself is a veteran, and she loves nothing better than going out to veteran events in Europe on a regular basis, and nothing gets in her way of doing that. The Minister already talked about the census data. We know there are about 15,000 care homes. You could ask everybody and you'd get a very slightly different number, but that's roughly the right figure. And we now know from the census data that there are 26,500, give or take, veterans who live in care homes in the country. So there are 340-odd thousand residents in care homes. That's about 8% of veterans, and nearly half of the care homes in the country have at least one veteran living in them. So this is all from the census data, and it's been a game changer for us in terms of how we think about it. The other thing to reference here, obviously this resident is at the older age of her life, but we have residents in Royal Star and Garter homes as young as 35. So our age span is 35 to 104 at the moment. So let's not forget that there are also working age veterans that we're trying to support. And to pick up the Minister's point, if this is the best country to be a veteran in, then that includes care homes too. We've already touched on that there are a lot of NHS staff. There's even more social care staff, incredibly. And we care for collectively about 800,000 people, not just in care homes, in supported living, in home care, in domiciliary services, in a whole range of innovative, different community-based services. However, we run care homes. Taking on 15,000 care homes felt enough of a challenge to start with, so we are focusing on care homes. And care homes are not like NHS trusts. They are generally very much smaller, on multiple orders of magnitude. So there are a handful of very large care home groups in the country, and I'm delighted, when I come on to a later slide, that we've got some of those already signed up to be involved in this programme. But most are 1 or 2 care homes in a local area run by well-meaning people, families, with maybe 1 nurse or 2 nurses, possibly linked to a GP surgery, and the scale is enormously different. So that's often what the flavour of what we've been trying to do with the programme. We also focus on building long-term relationships. This is where people live, and hopefully live for a very long time. So again, different end of the telescope in terms of how we approach this. And there are only, and I run one group, thank you to Guy's introduction, we run 3, I think, very excellent care homes around the country. People are very welcome to come and visit. But there are only about 20 military-only care homes in the country. You'll know Chelsea, you'll know Royal British Legion, who run 6, Broughton House in the Northwest, various others. And it's been brilliant to create a partnership where 2 of those providers, so ourselves who run 3 and the Royal British Legion who run 6 care homes, working with the VCHA and with very generous support from the Armed Forces Covenant Fund Trust to be able to put this pilot together. But we have all dipped our hands in our pockets to get this pilot to work, and we hope that at some point we'll be able to have conversations about getting this onto a firmer footing. We also did some research in the beginning of this. So Anglia Ruskin and Northumbria University did some work that we commissioned with RBL and with Royal Hospital Chelsea, looking at those issues which are important to care home veterans, and that's in particular around social isolation, loneliness, being able to talk about traumatic experiences, and comradeship within care homes. And that's so important. And that's what we do as an organisation all the time. But our hypothesis has been that most care homes, which are working damn hard to just keep their head above water and keep a nurse on shift at the weekend and enough people in, are not thinking specifically about the social and emotional needs of the veterans in their community, may not even know that they have veterans in their community. And if there is a way that we can help develop that, that is a fantastic success for us as an organisation. The journey that we're taking people through is very similar, oddly, to the VCHA. We have adapted the 8 standards so that they are more social care friendly. The language is different. We don't talk about patients, we talk about residents. We take long-term views on things, we talk about keeping people in the services, and we don't look for the types of data that maybe would have come out of a fairly significant HR team within a trust, when most care homes would be lucky to have someone who even did the personnel work properly. So this is different scale. And I've already had a number of conversations about this today, and I would welcome many more. Once we've accredited people, we want them to support other homes in their area, to create a network, to really engage with the GPs and the hospital trusts, but particularly to help other care homes to be more veteran friendly. And that's going to be a very important part, I think, of how we work going forward. We're currently piloting the programme in the Northwest, but we are not turning people away if they happen to approach us, but the focus is very much on the Northwest. And we are launching officially on the 19th of October. It's a 2-year pilot officially, and we've already we'll be launching with the first advisory group meeting that we have, which includes people like Robin Simpson, Deborah Sturdy, members from the LGA and others coming together to make sure that we're just getting that advice to take this forward in the right way. And we're delighted to be partnering with the VCHA with this, so it's fully aligned. This is the feedback we've already had from some of the people that we've taken through. And in the middle is a quote from Anchor. And Anchor are one of the largest not-for-profit care groups in the country. So we're absolutely delighted that they are at the forefront of this. And we have also got Bupa involved as well. So from a non-start, non-launched, to have 2 of the largest care groups in the country involved is brilliant. We've also got some councils, we've got other charities and organisations involved. And we're starting to already see those small changes, the person-centred changes that we've already been talking about, coming forward. Catherine was telling me yesterday evening about a wonderful example where we now have a care home in the Northwest which is using the poppy symbol on residents' doors. And through that, a couple of residents realised they were both veterans and then talked to the care home about what they'd quite like to do together, which included going for a round of golf. And that is what social care is all about. And that all started because we have an accredited care home which is starting to put those leads together. I won't touch too much on this because others have talked about this in much greater detail already, but we hope we can be part of that improved data drive, really looking at outcomes, making sure that we're getting that integration right. ICBs we embrace fully, but we want to see social care as part of that conversation as well. And we hope that this accreditation programme with the VCHA accreditation programme is a really positive way of doing that. And with my Star and Garter hat on, I can say it already is, because we are talking to some of our accredited trusts and we're starting at a much better place being able to do that. So there's a real win here. The other thing, just to touch on, for those care home managers who may be thinking about why should we get involved in this, there are also, of course, and Paul will talk about this, I'm sure, lots of organisations out there, charities, third sector and statutory bodies who can help care homes to do more. If you can identify in a care home a veteran with a visual problem, I would hope that Blind Veterans UK would be leaning in on a very significant way. What a fantastic win for the care home. More for nothing. That, I hope, is going to be a very positive thing that we'll be able to take forward. And then finally, we are obviously keen to collaborate. We're here today, we're here every day at the end of Teams and emails. Please come and tell us how you think we could make this pilot work better. Some of the people in this room will run care homes or have incredibly strong links with care homes, and we would want to hear how we can use those. Catherine and Fran are desperate to hear more people, so they have more to do than they care to wish for, and that we hope when we're here next year, we'll have some data to be able to present. Kate touched on, we like having targets. We don't have any targets particularly yet. We'd really love to have some targets, but we are shooting to try and get about 1,000 care homes accredited in the next 12 to 18 months. And that is a very significant number to do. So please help us with that. We may not thank you as we get to 700, 800, 900, but we would appreciate the support. Thank you very much.
Thanks very much, Andy. And I just wanted to say a personal thank you for all your drive in terms of grabbing that funding to get that programme on the road. And of course to Catherine, who's at the operational delivery level, and we know from our days at VCHA. So I think care homes will be really well served by your small team there, and I include Fran in that. So next up really is H, as he's known. H graduated from Oxford University in 1994 with prizes in surgery and medicine, and is also a blue in boxing. He trained in surgery in London, Birmingham, Australia and the US, and his specialist interest is trauma and complex limb reconstruction, and he has been a consultant at Imperial College Healthcare NHS since 2009 and Director of Major Trauma since 2016. He completed a short service limited commission with the Parachute Regiment, and he's wearing his maroon tie today. Very nice, H. And has been a reservist for over 20 years, serving with airborne forces. He spent 4 years as a senior lecturer at the Academic Department of Military Surgery and Trauma and Royal Centre for Defence Medicine, and was deployed as a military plastic surgeon to Birmingham in 2009 and 2010, and Operation Herrick, Afghanistan, 10 and 13. He set up the Veterans Trauma Network, now Operation Restore, together with Richard Swarbrick, I think Richard's in the auditorium, to provide NHS physical healthcare pathway for our veterans. He assumed the role of chair of NHS England's clinical reference group for the armed forces in May 2020. H, over to you.
Cheers, Guy. And thank you, Tim and Guy, for the invitation to speak. It's a real privilege and honour. Yeah, like the other speakers, hearing that stuff come back means very little to me. I don't think that really happened, but clearly it did. And I will tell you that Birmingham was far worse than Afghanistan for lots of reasons I can explain. Anyway, so I'm here to talk about Opera Store, which is a new name for the Veterans Trauma Network. And what I'll do over the next 15 minutes is say what it is, who it's for, how it works, how it's doing, and what we hope to do next. So it is NHS England's physical healthcare pathway for veterans. It's designed by veterans, and it's aimed at veterans with complex health needs. And I think the armed forces team within NHS England is a bit of a disruptor, but I think Opera Store is a disruptor even within that space, because I think in theme with what we're talking about today about building links, we're trying to break down some of those barriers, particularly between physical health and mental health, between statutory and non-statutory provision, between clinical care and social prescribing. And so the aim of Opera Store is you generate a holistic care package that's focused around the veteran and their family. And I deliberately chose this picture just to remind us who our veterans are. Some of you may recognise this photo. This is 11 Platoon D Company 2 Para moving off from Fitzroy. Far left a picture, the last known picture of Private Dave Parr, who's killed a few days later on Wallace Ridge. But these are our veterans, okay? It tends to be male, they tend to be white, and they tend to be of that kind of age, 50 to 60, with MSK type issues. So who's it for? As I said, it's for people who serve in the armed forces. We know our definition of what veterans are. And it is people with continuing complex physical health issues that aren't being met by routine NHS care. Opera Store per se is only available in England, but I'll talk about the devolved administrations in a minute. And it doesn't really matter when it happened. It could be 2 months ago, we're seeing people coming out of transition, to 20, 30, 40, 50 years ago. How to work? Well, we've got the entry criteria, they've got ongoing physical healthcare problems. It's a GP referral in, so they've been triaged through their GP and been working with RCGP, with the Veteran Friendly Scheme, with Emily and Robin to kind of work out how we articulate that to our GP colleagues so they know how to appropriately refer people in. Once they've been referred in, we use Defence Medical Welfare Service to provide a veteran support worker who will work with that veteran and their family to understand what is the problem, and not just the physical healthcare need, but all the other issues, the mental health, the social issues. So we understand in a very kind of holistic way what are all the things contributing to that veterans and their families' ill health, what's stopping them having a full and fulfilling life. So the patient is then brought to an MDT, and we identify what their needs are, and then we work out a treatment package and work out how we're going to deliver that. And we try and keep it as simple as possible. So I think the real strength of it is the MDTs. So these tend to be led by a consultant from varying different clinical backgrounds, but often with a military understanding. Now, they may be serving military personnel, they may be reservists, they may be ex of both of the above, or they may be civilian. But the criteria we have is that they need to understand the military context, the narrative behind what our veterans and their families are presenting with. And it's a wide-ranging MDT. We have strong links with OpCourage, our mental health provider, and strong links with military charities. And we use DMWS with their veteran support worker as being the advocate for that patient to understand in that meeting what are the issues that need to be addressed. So we'll work out all of the options for how we deliver that care and who's going to do it. And if they do need to be referred across to other agencies that aren't present, then we can initiate that. That does not get pushed back onto the GP or onto the veteran. We will take that on board and get that sorted out for them. And then finally, we'll feed back. Initially, now we're just feeding back to the GP, but we're looking to feed back to the veteran as well to make sure everyone is in the loop of what's going on. And what that kind of collaboration creates is a safety net. So by having all of these statutory, non-statutory, mental health, physical health, healthcare and social care providers all together, we create strong links so that a veteran and their family can't fall through that net. And I think this is what we mean by creating a whole force concept. We're all linked together, so actually veterans don't fall through. Why does it work? Well, I think a lot of the veterans we have referred in have complexity. Now, that might be complexity around their physical healthcare need, but it may not be. Their physical healthcare need may be very straightforward, but they've got complications because they've got mental health issues or social care issues. Now, I'm a simple surgeon. I can cut stuff out and put it back in. I can't solve their housing. I can't solve their mental health problems. But by having collaborators around me who can do that, we can unlock all of those problems. So our kind of buzzword is, collaboration solves complexity. Because if we each pitch up with 10% solutions, then we can knock off all of those veterans and their families' problems. So 10 of us together will create a 100% solution. So I think, we often talk about collaboration and holistic approach. I think this is a genuine collaborative, holistic approach and is absolutely patient-centric. And by aligning those offers, I think we deliver more efficient care and therefore it's more effective care. And by having everything cohered in one place, it also facilitates learning. So we can look at what we're doing, measure how we're performing, and make sure we're doing it better each time. And all of that, I think, adds value to the veteran and their family. They're getting more effective, more efficient care, but also adds value to the providers because we can now engage around our areas of expertise, knowing that anything that might prevent our service being delivered and being effective for a veteran is addressed. So, for example, if they're not attending hospital physical health appointments because their mental health is bad, if we sort out their mental health, their physical health can also be delivered more effectively. So I think, linking all these things together really helps drive the care the patient and the veteran and their family receive. So how's it doing? It's getting busier and busier. We've had, I think, as of this morning, 776 referrals. This is the chart of our progress. You probably can't see it, but the inflection point is the year 2020-21. And I'd call this the Kate Davis stroke Beth Lambert effect. So that's when Kate looked at this model and said, you know what, this is really good. We should be doing this. I'm going to support this. And funded us, gave us a program manager called Beth Lambert, who unfortunately can't be here because she's got COVID. And I think those kind of putting that structural support in there really drove these changes and drove that real uptick in uptake. As I said, we're only available in England as Opera Store. We supported colleagues in NHS Wales to set up VCHA Wales in 2019. And we've been working with colleagues in Scotland to set up an equivalent service in Scotland, which is going live this year. We're also having conversations with the Northern Ireland Veterans Commissioner to see what can be done in Northern Ireland, but clearly that's a far more complicated both health and political space. The areas we're focusing on at the moment, we realise that chronic pain is a really important issue for our veterans. About 80% of them have chronic pain, and NHS pain services are overwhelmed. So we're looking at ways that we can understand how we can address that need more coherently, both using NHS services with support by other military charities. And we're also really focusing down on transition to work with our MOD partners to make sure that when people are leaving service with ongoing physical healthcare needs, they don't drop off a cliff, and they are seamlessly referred into us if that's appropriate, and we make sure their healthcare is maintained or continued. So what do we want to do? We want to do more. So if you remember that safety net, the more people we have in that safety net as contributors, the stronger it will be, the more links there'll be. So we want more partnerships, both from within the health service and more trust. So if you're a VCHA accredited trust, can you support us? Can you provide services that we could use? If you're a charity, are you linked with us? Because as I say, the needs of our veterans are really diverse. And the more charities we have engaged, the better we can service those needs. And we want more feedback, both from providers, both from our charity partners, but also from our patients. And if we do all of that, I'm hoping we'll get far more veterans coming through the system and hopefully benefiting from it. And I think we'll all agree that if we do that, we create that single system, we'll deliver far more effective care. And that, I think, will go a long way to make the UK the best place to be a veteran. Thank you.
Thanks, H, and I know you've got a pretty demanding portfolio, so thanks for getting here, especially during the industrial action as well. We're now going to head across to the Defence Medical Welfare Services, and I want to hand you over to Paul, the Chief Exec, who's an experienced business executive who has spent 35 years in industry running both large and small organisations. After an initial career on the gold and diamond mines of South Africa, he moved into the IT sector and joined IBM as a systems engineer. From there, he gained experience across all functions of the business, including project management, marketing, business development, contracting, operations and consulting, eventually as the executive responsible for the e-business consulting team across Northern Europe. He's also had numerous roles at the exec level with both Rakel and Dell. Over the last 6 years, however, he's been the chief exec of the DMWS, and Paul has used his business expertise to transform DMWS into a diverse organisation with multiple contracts providing medical welfare provision to all armed forces, both serving and veterans, and indeed their families. In addition, he has led the drive to make these capabilities available to a broader cohort of personnel who are also serving the nation on the front line in stressful and potentially traumatic roles such as blue light services and indeed NHS staff. Paul has sat on the executive committee of COBSIO, Confederation of Service Charities, for the last 6 years and is chair of its finance committee. Paul?
Thank you, Guy. Very nice introduction. I think I wrote it. But absolutely delighted to be here today, and the brief really was to tell you all about DMWS, Defence Medical Welfare Service, where we're going and what we're doing. So that's the plan for the next 15 minutes. At the most basic level, what we do is we provide welfare support to the armed forces, both serving veterans and reservists, cadets, but also very importantly their families. And we provide that support when it's in a secondary care setting in the main, and hence the strong interlock here with all the various elements of NHS services that we interlock with. We also, as Guy just alluded to, and some of the other presenters talked about, we have taken the expertise that we've gained over the years and started to apply that into other frontline service type organisations such as the police and into care homes and other groups. That's very important because we're not only using the experience we've gained from the armed forces side of things, but we're also able to take learnings we're taking from those organisations and bring those back to improve the service we're providing into our serving personnel and into the veterans. So there's a virtuous circle of support going on there. From a history point of view, this is actually an organisation that was formed in 1943. So this is our 80th anniversary year. And we were very much formed by the government asking St John's and the Red Cross to form an organisation to support service personnel coming back from the front in the Second World War. And in truth, the core of what we do from that day to now hasn't really changed hugely. We are looking after those folks. We are helping them with any non-clinical issues that they may have. We work alongside the medics, and we're taking that holistic approach that H just talked about in terms of what's the overall situation that this individual's in and their family's in, and how can we support them. And that has many positive impacts on supporting all the things that NHS are doing, and likewise what the chain of command are doing in the case of the serving personnel. We've deployed to the front line with the medics on various conflicts. There's lists there, and we still have staff that served at Camp Bastion in Afghanistan. But we are all about, as Andy said and H has said, it's all about partnership, collaboration, and working together with the various organisations we're helping. In terms of NHS trusts, we are currently have teams embedded in 44 NHS hospital locations across all the nations, all the devolved nations and the UK and England, as well as working in 9 hospitals in Cyprus with serving personnel. And that support within the secondary healthcare area also extends out into the community when it makes sense to do so, or will support people go into other charitable organisations that can help with their rehabilitation. The other thing we do is work very closely with hospital trusts to help them get their accreditation and to understand what the covenant means and indeed to get them to sign the covenant. And in many cases, the data that they can collect, that we collect on the ground, actually very much helps them in terms of understanding the veterans that are in their environment. So what do we do? So we do 2 things really. This is a list of things we do for individuals that come into the hospital. So number 1 and one of the most important things is we are an independent entity. So we're not part of the NHS, although obviously we're very well integrated with the NHS. We're not part of the chain of command if it's a serving person. We are an independent organisation. And this is all about building a relationship with the patient, the service user as we would call them, and getting their trust. Because often what they present with in a hospital setting may be a symptom and are caused by something much broader in their life. And so understanding that cause has many benefits. A, we gain their trust, but B, we can look at what are the underlying cause and effect of why this person is presenting within this setting. We don't have any limit on the number of interactions we'll have with individuals. We're there to help them until they're sorted out. It's a combination of face-to-face visits, but also telephone support, subsequent online support, etc. We will go with people to visits if they don't feel they can or they have transport issues, and we will identify their broader needs, things like debt, housing, etc., so that we're trying to fix those underlying problems. We won't do all of those things ourselves. As Andy said, we will work with the rest of the third sector to try and resolve some of those issues. There's about £1 billion worth of funding in the third sector for armed forces charities. That is a significant amount of resource, money and capability. And so having a gateway into that saves the NHS a lot of money, but also utilises those and makes sure that when a veteran is on a journey of recovery, they're getting access to all those things. So in this setting, we can act as a gateway into all those various services. And indeed, the Confederation of Service Charities, COPSIA, is an umbrella organisation that works very hard to make sure that the various third sector organisations are linked together and are going through the process of joining all the dots. So if you don't know about that organisation, I suggest that you look up COPSIA online. We will not throw somebody over the fence to one of those other organisations, be it statutory or third sector. We will remain in contact with that person until we know that the onward referral has been effective. And if it isn't, then we'll take them back on board and work through another plan with them. We certainly act as translators, so we can translate between army settings, medical terminology, and often when people are given a diagnosis, quite a shock, they may not quite have grasped what that means. So we can take the time outside, free up the clinicians, but we can take the time to explain what the implications of that might be, what impact it may have on the family, etc. So I do see us as a translation facility as well. And we do get situations where conflict happens between family members. Several cases where we've stepped in and helped, freed up clinicians within the trusts, and we've taken on the resolving of the wife, girlfriend, and ex-wife all in the same room at the same time, for example. So very important in terms of helping that person through their experience within a secondary care setting. We've a very tried and tested process for doing this. It's really based around the needs of the individual service user. We always put the service user at the centre of everything that we do. And we will get referrals. We get referrals from multiple different places. If it's op restore, it will come via the GP, but it can just as easily come from NHS staff on the ward. And we will work with that service user to really understand what their needs are. And it's all about what they need. We will work with the clinicians. Obviously, the clinicians will have a view on what treatment is required, but then we'll work through that with the individual. And then we'll go through a cyclical process, looking at their wellbeing needs until we've got both emotional and practical support needs identified. And really what we're trying to do is enable that person to solve their own problems. Obviously, we'll have some expertise in where they should go and where they should talk to, so it's not really a hand-holding service, it's an enabling that individual to help themselves, and that's the philosophy behind it. And then we'll do any onward referral if required, and engage with other third parties and statutory. And then we'll work out what they need. That last box there, data and outcomes, is very important. We've invested a lot of money in our data capture system. We do have most of the things on the list, and Bernadette's going to talk about that. Your data set 1 and data set 2 we do collect. But I think we can really help and collaborate with everybody in terms of those. How many people do we help? So last everything's in financial years because of my background, I think. So we helped 4,125 patients, stroke service users, and in addition, 3,000 family members. And in several of our cases, the actual service user may be in a coma or may be slightly out of things, but we're there to catch the patient's family, which is just as important in terms of helping with recovery. And we do a lot of work in terms of educating NHS staff. Kate mentioned earlier around some reticence sometimes with the armed forces cohort. Well, we're there in the ward, on the ground, to help them understand the terminology and what approach can be used. A little piece from the data. What we can see here is the spread now of where we're covering. 2 years ago, that was about half as many dots. The different colours say that we can tell if the veteran is from the Army, from the RAF, from the Navy. We can get a sense of what their background is. And you can see the split of work that we did in that year. So nearly 2,000 people were veterans, 1,000 serving, and 600 family members. And you'll see police officers coming up. I think we're at about 450 police officers now, so it's become about 5% of our work. Most important and key are our people, and I see some DMWS t-shirts in the room. We have a fantastic team. We do not have any volunteers within the organisation apart from our trustees on the board, and that is a deliberate decision because in this environment professionalism is key. And so we invest in training. We developed our own diploma in welfare. We've just revamped that completely, and that's focused on both mental health and physical health, and so everybody goes through that process. A lot of our staff come from the cohorts we're supporting, be it from veterans or veterans' families or serving families, or from the police force, so that we've got that empathy in place. This is a list of what we have within the training. I'm down to 2 minutes, so I'm not going to go into detail in that. But I did want to just mention that not only do we have a list of things that we help the individuals with, but in terms of an NHS trust, some of the things that we can really help with is monitoring how much bed blocking. So we can unblock beds. We can stop people not attending, i.e. get people to attend. We can catch things before they become the next emergency. So we actually have quite a serious preventative element to what we do, and it stops people coming back and being repeat visitors to the hospital. So if you need to put together a case for putting somebody like a DMWS person or other third sector people into help with that broader wraparound for your veterans, then we can help you build a business case that your executives, who probably are more interested in money than anything else, you can leverage that and show them how they can save costs. At the end of all of this are individuals. So I'm not going to read this story, but really this is an illustration of an army veteran who fell on bad times, did try to kill himself, was homeless, had mental health issues, all the op restore, op courage, etc., op fortitude in terms of homelessness. It's a classic example of catching someone when they're really at their lowest and working with them to help themselves, and that person now is out sailing, he's doing other things, he's got his self-respect, self-confidence back, and at the end of the day all that we do is about helping people like that. So that was all I had. Thank you very much for your time.
Right, ladies and gentlemen, welcome back. I hope you enjoyed your lunch. We're now going to start the sort of the second part, I suppose, of today. And this is really, I suppose, where the rubber hits the road in many respects. But first up, I want to introduce you to Miss Alex Crick, who qualified from St Thomas's Hospital Medical School in 1992. She completed research in the development biology of congenital limb malformations, and for her MD thesis as a Wellcome Trust Fellow at the University of Oxford in 2002. She then trained in plastic surgery with the Wessex and Oxford region, finishing with the Hand Fellowship at the John Radcliffe Hospital and Nuffield Orthopaedic Centre in Oxford in 2007. Her principal interest is microsurgical limb reconstruction following trauma, working with colleagues in Sailsbury and Southampton to develop the acute orthoplastic service for the major trauma centre. Alex is a consultant plastic surgeon at Sailsbury and was appointed in 2008. And I think it's also worth noting, and I know Alex will kick me for this, she's probably operated on more veterans from Afghanistan than anyone in UK in terms of reconstructions. Might be wrong there, but that's what I got off the internet, Alex. So Alex, over to you.
I think you made that all up, Guy, because I didn't send you anything, did I? No. So I think joining the dots was a strapline that you came up early on for the conference, and it put me in mind of a phrase that David came up with at the conference in 2021, a tapestry of care. So this is obviously a tapestry, and what we're all doing as individuals, as organisations, we're the individual threads, and because we're expert and we're collaborating, we're creating this beautiful big picture, but I'll come back to that at the end of it, at the end of my talk. So some of this is old news for everybody here, but it's worth saying again. The Armed Forces Covenant, as we know it now, was first published as part of the Armed Forces Act in 2011, and that was a statement of moral obligation only. And then it was reinforced and strengthened as part of the Armed Forces Bill in 2021, and it is now a duty. It's our duty to pay due regard for the principles of the Armed Forces Covenant, and that applies to certain public bodies, including the NHS, in certain of their activities, including healthcare. And the principles of the Armed Forces Covenant are to appreciate the obligations of and the sacrifices made by the members of the armed forces, and that it's desirable to remove disadvantages of being a member of the armed forces, and that special consideration should be is justified for certain members of the armed forces, depending on the effects of their service on those individuals. So from a hospital's point of view, and that's why I've been asked to talk, I think it's we're both an employer and a healthcare provider, and these are the phrases that are I've quoted from the Armed Forces Pension Commissioning document. So veterans should face and serving should face no disadvantage compared to other patients in the provision of healthcare. And this is relatively straightforward. For example, if somebody's moving and their child is on a waiting list for a procedure, it's relatively straightforward to transfer that relative position on the waiting list from one hospital to another. The more difficult areas, this special consideration is appropriate in some cases, especially for those who have given most, such as the injured. And the document goes on to say, we expect our providers to offer priority treatment to veterans for service attributable conditions subject to the clinical priorities of other patients. And this is much more difficult to deliver, partly because we don't specify what is service attributable, and the subject to the clinical priorities of other patients is often overlooked or misunderstood. So that might be something that we discuss in the panel at the end. With B's help, thank you very much, we achieved reaccreditation with the VCHA in 2022 and got the Gold Award for the Defence Employer Recognition Scheme as well. The latest version of the Armed Forces Covenant does not specify how you deliver on this duty to pay due regard, and I think the accreditation process with the VCHA sets a standard that means that we can all be consistent in our approach to delivery of that promise. So in Salisbury, I think we have a few advantages in Salisbury. We have history on our side. The US Army set the hospital up during the end of the Second World War as a field hospital to receive casualties from France and later the D-Day landings. And then in 1949, after the advent of the NHS, the Regional Plastic Surgery Department moved there as well. And John Barron, pictured here, was the first clinical director of that department, and he is still the most famous surgeon to be associated with Salisbury. He trained with Harold Gillies, who is the the father of modern day plastic surgery, and famous around the world, in fact. We're also a small hospital. We're a district hospital, but we punch above our weight, I would say, because we're a regional plastic surgery service as well. And then my own war injury clinic receives patients from all over the UK. So we serve, as a regional plastic surgery unit, 3 counties with 3 million people. And we know from the census data from 2021 that 1 in 25 or 3.8% of our adult population are veterans. But there are regional variations, and the Southwest has the highest concentration of veterans at 5.6%. So that's where we sit. And in fact, this is information you sent me, 22% of the population I serve is armed forces community. So the point of this is that it's veterans are core NHS business for everybody, but particularly for Salisbury. The other data that was of interest from the census was looking at the self-reported overall health from veterans, and once you've adjusted for age and sex, it's very similar to the rest of the population. This is a bit counterintuitive for me, because we all I'm aware that veterans present quite different mental and physical health problems to me in the hospital, as well as there being cultural differences. And the special consideration that we're familiar with in the Covenant is a moral one. But actually there are other justifications for developing specialist services for veterans, I think, in hospitals. And that's where expertise comes in. I was pleased to hear Kate refer to quality in terms of the services that we're developing. And I think part of that is expertise, and that's particularly true of the patients that I'm particularly familiar with, which have military-specific injuries, particularly combat-related injuries, having been blown up or shot. There aren't many of those patients, and it pays to see somebody who's familiar with those injuries. So the War Injury Clinic is something that I started in 2008, so quite a long time before the VCHA. And I was, along with my colleague, Rod Dunn, was seeing people who'd just been injured in Afghanistan. They were going through their rehabilitation at Headley Court, the DMRC Headley Court. And the clinic was set up to look after them and undertake the secondary reconstructive surgery for them while H was busy in Birmingham. So, and a lot of people say, why do you still run that clinic? You know, you're not seeing those patients anymore, but I am. I'm seeing those same patients as veterans, and that's because things change over time as they age. They develop other injuries or other medical problems that are influenced and complicated by their previous injuries. And I see plenty of new referrals, you know, people who are new to me, who were injured in Afghanistan or other conflicts, because they know that they're coming to see somebody who's familiar with those injuries. And I still see serving personnel referred from the teams at DMRC, which is now in Stamford Hall, because not all, you know, a lot of serving personnel with medical problems are managed within the NHS more broadly, not just by my military colleagues in Birmingham and so on. I'm very, very happy to be one of the clinical leads, part of Op Restore, as a sort of acknowledgement of my unusual experience. The clinic is still unusual in that it's the one of the only clinics that sees specifically and only military patients, veteran and serving. And from fairly early on, we had military charities embedded within the clinic. And I think a lot of the progress that we can make in general will be to further the integration of the military charities with what we do in the hospitals. And that's a picture there with, standing up at the back, Carol Bettridge, who's the clinical lead for Help for Heroes, and her deputy, who's with us, the Help for Heroes stand downstairs, is usually with me in clinic. We have Blesma on speed dial. That would be Pat Donaghy, who replaces Bill Gillett here. And I've got Matt Long from DMWS, who is associated with the hospital, and he's on standby at all times. So this creates, you know, a patient might be referred to me with a low limb problem, but while they're there, I'll ask them about all their other injuries and everything else that's going on in their life, and I can signpost, with the help of my military charity colleagues, to anything that I think they might benefit from. Now I'm going to, because I've got 5 minutes, rehabilitation. This started with the Andrew Murrison's report in 2011, A Better Deal for Military Amputees, the Schvass report, and Improving Veterans MSK Rehabilitation report in 2022, and I was part of the reference group for that. Of all the lessons that we've learned from treating those who are injured in Afghanistan, one of the things that we haven't really translated to the NHS more broadly properly is rehabilitation, and I'm very pleased to be part of the rehab project for the VCHA, piloting the recommendations from this report authored by Maisie Proven. If you're going to make a difference make any progress with what you do with looking after veterans or developing those services within a hospital, you need some leadership and you need a team of individuals, ideally who have key roles within the hospital or particular expertise. But the most important part of what I do, I would say, is connecting the veterans that come to our hospital, identifying them, identifying that they have some unmet need and connecting them to all that the military charities have to offer. And the way you do that is, I think, by training the staff. So instead of having one Armed Forces champion, we have I'm hoping to have every member of staff to go through our Armed Forces Champion training. And then you need, the other essential component is to have somebody like Matt Long, DMWS, who's assigned to the hospital, because the best person for knowing what support there is for from any particular charity is somebody who works for a charity already. You have to have an idea of what's on offer, but you don't need to know the specifics. You just need to know somebody who does know that. So the training involves myself and Blesma and Health Heroes and DMWS. And we explain what the Armed Forces Covenant is, and what it means for a hospital, what the military charities have to offer, and what their part might be. And they leave with a certificate of attendance, most importantly a badge. And it sounds like a really simple thing, but if you walk around with a badge, then it initiates conversations more easily. And they are my eyes and ears throughout the hospital, and they initiate those conversations and refer those patients to Matt within the hospital. And of all the things I've done in the hospital, this has made the biggest difference, I would say. Data, in terms of demonstrating progress, that's really difficult. Again, one of the advantages of having somebody like Matt in the hospital is that his data is the most useful data from the data capture pilot point of view. 2 minutes. So I'm coming back now to the tapestry of care concept. So this is the reverse of a tapestry, and this is truly what the NHS is like, I think. It's really complex, isn't it? And it takes us a while to really understand it. We understand it because we're immersed in it. And you can imagine how difficult it is for a patient, any patient, particularly a veteran, if they've had a long service and they're used to things being much more straightforward while they're serving. And this is not what we want the patient to see. I didn't mean to do that. There it is. So this is what we want the patients to see. Something that completely makes sense. And this only happens with collaboration between the NHS, all the military charities, and together you can create an image like this. And what we're aiming for is to develop services that support our veterans, that is easily navigated, it's individually tailored, it's responsive, it's comprehensive, it's expert, and it's available through life, not just for that spell in hospital, but before hospital and after hospital, which is where the military charities are particularly useful as well. And it benefits everybody, not just the veterans as patients, but the staff. It's incredibly rewarding work to be involved with. The hospital and the NHS in general, because you get patient, from a financial point of view, you're getting patients home earlier and reducing their readmission rate. For the armed forces, because it delivers on our promise to look after them if the worst comes to worst, and for society as a whole, because it reflects our belief in the moral obligation, the promise of the covenant. So you should view it as this activity as a win-win, win-win, win-win. There is one more slide, but thank you very much.
Thanks very much, Alex. And you never cease to amaze me. And I have to say, I'm just going to quote from my text messaging last night. At 2026 last night, 22:26. Alex, are you okay? Alex comes back to me and says, yeah, how is the best way to send this presentation to you? She then said, I've just sent an email. Sorry, guy, long day. And that just, sums up life in the fast lane as a surgeon, which is just absolutely incredible, Alex. So thank you very much for that. So we're now going to move on to the ambulance service, which again is another part of that healthcare pipeline, another touch point. And I'm really privileged to have some really good speakers, actually. And I think I want to introduce Professor Sir Keith, who's in the ambulance service. Prior to joining South Central Ambulance Service, Sir Keith was the National Director for Emergency Planning and Incident Response, as it was then NHSEI. He led on national service transformation across the NHS in England for 12 years including the EU preparation and the operational response to coronavirus. Keith is a highly experienced clinician, having worked in the NHS for over 40 years as Professor of Trauma Surgery at the University of Oxford. He has extensive experience of trauma and emergency care. Healthcare management has been instrumental in driving service transformation and working collaboratively with partners in the NHS and beyond. Keith has presented research and taught surgery and health leadership extensively in the UK and indeed internationally. He was deployed as a civilian on missions to Afghanistan and Libya during their wars. He was awarded a CBE in 2016 and Knight Bachelor in 2021, both for services to the NHS. He was appointed Honorary Air Commodore to the RAF Auxiliary 462 Aero Medical Squadron based in Brize and Orton. In addition to chairing South Central Ambulance Service NHS Foundation, Keith also chairs the Council of Association of Ambulance Chief Executives. He's also got his senior manager with him, Paul Jeffries, is a senior manager and leader within the NHS Ambulance Service and is currently the Assistant Director of Operations in South Central Ambulance Service. In this role, he is the Operations Lead, Military Champion for the Trust. Paul has worked in the NHS for 31 years now, but also has a strong alliance with the MOD since being in the Army Reserve, as well as being involved in the Army Cadet Force. Due to these associations, Paul has strong links with the military network in the South East. Paul really values the benefits that service personnel bring to the service, and he has been hugely instrumental in enabling joint working initiatives at the ambulance service with our MOD and DMS partners. So Sir Keith and Paul.
Thank you. And it's not about us, is it? It's about the Armed Forces personnel and it's about our veterans. And actually you're here to listen to PJ, not me. But I just wanted to give a personal reflection as to why I'm so committed to what we're talking about. So let's move on. Which it's not. Not that one. I don't need that. Okay, we don't want to see that picture. Let's move on. But what, for me, it's blindingly obvious in my 42 plus years in the NHS, is there's got to be a mutual benefit. There's an interdependency between the Armed Forces personnel, the veterans, and there's an enormous unfulfilled potential. And that's where we need to move forward. Now, I'm going to press the right button again. I was deployed to Afghanistan, mainly to sort out the reception arrangements for military personnel coming back to the UK. But also, it was very obvious then what the NHS could offer the armed forces in terms of releasing the reservists and the regulars. I'm now part of the reservist squadron. And again, it's blindingly obvious where that overlap is and how people benefit mutually between sharing those skills, and how the NHS is the place by which those competencies and skills that are learnt during conflict are maintained during peacetime. For me personally, I was deployed to Libya when we had no boots on the grounds, and I can tell you what I'd learnt from the armed forces, although not being part of them, were vital to me during that deployment. And by the way, when your boss says to you, we've got a little job for you, read your contract quickly. I didn't have this clause in it. So some very good South African, Australian mercenaries that looked after me. But it comes home really to roost when in the NHS is asked to respond to national emergencies. And these were some of the ones where in my national roles, I was so grateful to have the contacts and link in with the armed forces and how we could support the NHS. And coming to the ambulance services, there's a real opportunity in the ambulance services. And the reason I joined the ambulance service was not around those parts that I've already discussed, but it was really because the ambulance service, like general practice, is where the care navigation really starts, where the NHS first meets patients, and the opportunities for us to be able to provide veterans with the care and the opportunities is much greater. So yes, we can help Defence Medical Services maintain competencies and skills retention. Yes, we can use those skills in the NHS when the NHS needs it, but also the NHS offers enormous opportunities for veterans in terms of career extensions. We need to be the employer of choice. So in the ambulance service, we need operational people, we need logistics people, we need engineers, we need fleet managers, we need hazard area response teams. And by the way, we could do with some paramedics, nurses and doctors. The NHS has over 350 professional roles in its armament to offer veterans, and that's a really big part. And there's no better way to infuse an awareness of veterans' needs than to bring them into the NHS. And even more important, we're at a critical juncture in the NHS currently, where the solution has got to be around integration and maintaining care in the community. And that's where the ambulance services have a key care navigation integration function. Nowadays, 50% of patients who dial 999 are not conveyed to hospital. They're provided with responses in the community. We don't use the veteran responses that we have available, and we certainly don't coordinate that, which is, I joined ambulance services to do that integration for the public, but also for veterans. So we've reaffirmed what we're going to do as an ambulance service, and as the chair of the Council of the Ambulance Service Chief Executives, we're prepared to use that vehicle nationally to try and catch up with what GPs and secondary care have done already. And I'm offering that basically today. But what you really want to know is, what progress have we started to make in ambulance services? PJ.
Thanks very much, Keith. First of all, thank you for inviting me today. I'll move on because you don't need to see that. This first slide is probably quite complex and busy. It shows what we as an ambulance service are doing. So it's how we raise the profile of veterans and military forces within our organisation. Because to give a context, we cover 2,500 square miles. We've got military bases to include Windsor, Portsmouth, RAF Brize Norton. So we've got a potential huge pool of veterans living and working within our area, as well as currently serving. So I'm going to talk about collaboration, learning and celebration. So, collaboration. As a trust, we collaborate with our current service personnel to understand the needs that they have as service users, as well as identifying those veterans that they're aware of within our communities to enable us to best support them. We also have strong educational links with the military, where we provide placements for military paramedics. We support their newly qualified paramedics, and we have a network of bank paramedics that are military personnel that give their time to support us as an ambulance service, because it's really important that military are very good at trauma and dealing with the battlefield element, but we as an ambulance service do health and social care. We've got a really good recruitment team, and Laura's here today, and she's our link to make sure that our military veterans see us as a really good employer of choice, and also integrate with us as a service to make their transition from military life to civil life and future careers more effective. We also did a lot of work under the military aid to the civil authorities during COVID, where we used our military co-responders really effectively to positively crew ambulances to allow us to respond to our patients and those veterans within the community. As well as we set up a logistics cell that the military supported in totality to allow us to distribute and use PPE effectively. And also we've collaborated to be instrumental in the setting up of the National Armed Forces Network. Learning. Through learning about what networks are available, we gain knowledge to ensure the service users get the right care first time. A really good worked example is the VCHA produced a point of contact poster. Now for us as an ambulance service with a mobile workforce over 106 sites, 2,500 square miles, it's quite difficult to display a poster. So we used innovation and technology to make this poster available on our SCAS Connect, which is about urgent care pathways, which all of our clinicians on some 170 operational ambulances every day have access to. So when a veteran identifies themselves to us as in crisis or need of help, we're able to use this really good piece of information to signpost them effectively to the right care, right time, first time. We also use new initiatives. So we now capture armed forces detail on our staff record system, and we've got a system to allow people to get an interview providing they meet the specification for the job. So we're making it as easy as we can to integrate veterans into our workforce. We're also doing staff training where we're targeting our frontline clinicians to make them more aware of veterans. We've got new initiatives around our military champions within the organisation. We'll do local level inductions with those veterans joining us as an organisation to give them support in the workplace, in the area of the workplace that they're going to be within. We also have a really strong military champions network which meet regularly, and we're just setting ourselves up as a formal group. So our military veterans are represented at executive level within the organisation. We're also training our staff. It's okay to ask a veteran, are you a veteran? What can I do to help you? What do you need from us? And we celebrate success. We celebrate what we do in our communities via our websites, via social medias and webinars, as well as internal communications to our staff. A really good example of how we celebrate is when the NHS celebrated 75 years earlier this year. We as an organisation, in partnership with the Careers Transition Partnership, hosted a Military Insight Day. So we got our organisation together and we hosted, within our veterans and military networks, a showcase showing all of the opportunities available to veterans within South Central Ambulance Service. This was really well received and we had very positive feedback. It was hosted by the operations team and supported by our recruitment and education colleagues. And to make sure this was as high profile as we could, we also did it against the backdrop of Military Forces Week. So we as an organisation identify military forces as key to our service delivery. So in summary, we collaborate so we know that what we are doing is right for us as well as those we serve. We learn from our patients, our staff, and from one another. Then we review and revise to make sure we improve. We celebrate to show all of our stakeholders how important it is to support veterans and service leavers within our communities. So what are the three things I would ask you to take away today? I'd ask you to collaborate to allow you as organisations to grow. I would like you to learn so you can develop and be the best you can be. And more importantly, celebrate the successes as well as analyse the journey to make sure that the pathway you offer veterans and our service users is the right pathway. And I've probably got about 2 minutes left, so I'm sorry, but I was told to stand up, speak up, and then... So thank you very much.
Great stuff. No, thanks very much, Sir Keith and PJ. Really impressive. Thank you for the offer of help to try and take it forward, certainly from the highest level, and we'll follow up on that, Sir Keith. So thank you. Right, we're now going to move back into the sort of direct healthcare pipeline. We're going to move to St Catherine's Hospice, Scarborough. We've got the Chief Exec here, and we've got the Deputy Chief Exec. Michelle is going to present as the Deputy Chief Exec, and she's the Director of Clinical Services at St Catherine's Hospice in Scarborough and Strategic Clinical Network, Clinical Palliative and End-of-Life Lead for the North East and Yorkshire. Michelle qualified in 1991 as a nurse in West Yorkshire and followed a short time working in Leeds. She returned to her home region of the North East. She has a diverse clinical experience in the acute hospital setting and in community services. She has delivered and developed services in end-of-life and palliative care since 1996 in hospital, community, mental health, university and hospice. She was a broad management and leadership experience, also has a master's in healthcare leadership. Her passion is for excellent patient-centred care, service innovation and development, staff development, coaching, customer experience and innovation. Michelle recently led St Catherine's to become the first hospice in the UK to receive Veteran Aware accreditation. Well done. She is also the proud wife of an Army veteran. So, Michelle, you have the floor.
Thank you, everybody. Thank you very much for the invite to speak today, and I hope everybody can hear me at the back. So, St Catherine's Hospice. I like pictures, and what I wanted to do is put some pictures up there to show you how beautiful North Yorkshire is. Those are pictures of our hospice, our beach, and if you've never been, please come and see us, and you're very welcome to come and have a look at the hospice as well. As you can tell, I'm not from Yorkshire, from the North East. We're very proud to work in Scarborough and proud to work in North Yorkshire. So, joining the dots, where are we? So I think where we are as a hospice is that we are a hospice building based in Scarborough. We have about 130 odd staff, but we cover 1,600 square miles of North Yorkshire. It's a big patch. And I think we're very proud, very, very proud, and I was deliberate to put that first, to say that we're the first hospice in the UK to get accreditation. And I have to do a shout out to Cumbria, Northumberland, Tyne and Weir Foundation Trust for their help and support, helping us, they're a gold award winner, to actually start our journey and get to where we are now. I think we're committed. We're absolutely committed to making this part of what we do for everybody. We're a hospice. We always want to be excellent. We want to do our best. And every contact matters with our patients. And we're committed to making that even better through our Veterans Aware status and our knowledge and our experience of what we can do for these patients. We're engaged internally within the staff, and I'll come on to that, and externally, and trying to do even more with that with our networking. And flying the flag. I am very happy as the first hospice in the country to help any other hospice out there to go on the journey to get their accreditation and come along and join us. And we're really, really quite excited. We're excited about where this can take us, where it will lead, and actually the connections we can make. And we're already seeing that it's coming to fruition already. And some of the connections we're able to make in the community, we'd never have been able to do if we hadn't started this journey. Where we started was, I am from the NHS, 25 years or so previous to this, and my organisation that I was in was a gold organisation. So I knew that this was in the NHS, and I was poised and ready, waiting for this to come out of the NHS into other sectors. I think I'm used to having lots of military connections around me, and I think when you have that, or you have family members, there is an understanding that what it means on a personal level, what it means to have people that have served or are serving, and the impact that can have on people and the families and their loved ones around them. And we like to put ourselves forward for things and be proactive. So what did we do? Well, I think the key thing was that this had never happened in a hospice before, so we worked with the national team to think about how accreditation and the manifesto and all of that comes with it would fit into quite a small organisation that doesn't have an NHS infrastructure around it, and worked to see that actually it could all fit, it would just fit in a different way. So we spoke to NHS partners and figured out how we could do this on a smaller scale and how they could support us. And the first thing that I did was I did a survey of the staff to figure out who we had within the staff group that were either reservists or veterans or family of people that had served. And I got a surprise, actually. There was a lot more than I expected for a very small staff group of 130 odd people. And then I started talking to people, engaging with them and saying, shall we do this? Can we do this? And will you come and join me and we'll do it together? So we identified some champions, and then we started to think about, well, that's one bit of it. How do we identify the patients? We're a very rich, small organisation with regard to infrastructure around IT and digital working. And I was able very quickly to build into our admission process and our outpatient processes questions to ask, have you ever served? Have any of your family ever served? Are you serving? And actually identify that at our first contact with people, be it when they came in and were possibly poorly, but ideally in the outpatient setting before they actually, earlier on in their patient journey, in their illness journey. So we identified those patients, and the first couple of quarters data that we looked at, I was very surprised that there was about 70 patients and family members that we'd identified, that we'd had contact with, far more than I expected. And then we thought about actually how do we start looking into the community. And the time that we were doing this was just around the time when it was Armed Forces Day, and it was being held in Scarborough, the national event. So we got ourselves out there and we made ourselves visible. These are two of my champions. This is Alan, and he's on the maintenance team, and Pete, who's in his late 70s now, and he's one of our volunteers. And they rapidly, but nervously, got on board with me and said, well, how can we help? So our other champion is our chief exec, sat here in the front, and they needed a bit of, the guys on the screen needed a bit of support to actually think, well, where do we fit in this? But then when we actually told them what it was about, recognised the service, got them some training, they actually felt so valued that they could be of help. So where are we now? We are delivering an enhanced level of care, even for a hospice, because actually we've identified things that we can do that we wouldn't have known about before. We're supporting other hospices on this journey, and anybody out there that needs any help, as I've said, happy to help. And we're working with a couple of hospices specifically at the minute to share with them our learnings, our bits of paper, our processes, to see if that can be of any help for them. Thinking about new champions all the time. As we grow as a hospice, we're developing and growing at the moment and expanding and seeing how we can bring new staff on board that might have those connections, and actively seeing how we can recruit from the armed forces and the veterans communities. Working with partners and thinking about how we actually try, we're a hospice, we get a very, very small percentage of our funding from the NHS and from commissioning and ICSs. And therefore, a lot of this is done on raffle tickets, fundraising and goodwill sometimes. So we're always looking for new ways of finding resources that we can take into our building, use directly for the benefit of patients and their families. So always looking for new ways to do things. And thinking about how we can work and network more out into the community. We are, as North Yorkshire, and as that 1,600 square miles, we have quite a few military bases within our geography, and also thinking about how we can work with the cadet forces. So we're actively working with all the services cadets at the moment and seeing how they can come on site and help and volunteer and gain some experience with us, and actually find out that it's not scary to be in a hospice. It's actually quite fun sometimes. We're making links with mental health trusts and the Acute Trust around us, so that hopefully they're already within the scheme, and hopefully how we can link with them and come together in that partnership working. And we've been trying to awareness raise within social media and making videos, making posts, and just telling the community that we are veterans aware, and that if they ever have a touch point with us, that they can ask us and we will ask them, and we'll see how we can help them. And we have a video that we've made. It's quite short, but this is an example of one of the pieces of work. Hi, I'm Michelle Muir. I'm the Deputy Chief Exec and the Clinical Services Director. Veteran Aware Accreditation Scheme was originally rolled out within the NHS in the UK, and it's now being rolled out for hospices and care home sector, and it's about being able to recognise those patients and carers that we have that have either served or are currently serving, and also recognising the staff that we have and the volunteers that we have that again might have served. And then thinking about how we care for those staff, those volunteers, and obviously, most importantly, make sure that we give the best care possible to the patients and carers that we care for. When a patient comes into our care, gets admitted to St Catherine's Hospice here in Scarborough, or as part of some of our community services, we ask them some questions and ask if they've ever served or are currently serving in any of the armed forces. And if they answer yes to that, then that prompts us to actually think about what additional help or support we could offer them either through the education and the links we have here at St Catherine's or through some of the partner organisations that we now work with to ensure they get the best level of care possible for whatever their needs are for the illnesses that they have. As part of the Veterans Aware accreditation, you're asked to identify some champions within the organisation that might have served or are perhaps reservists. And those champions have a different level of education, some are able to notify the champions in the organisation, and they can go along, say hello, have a conversation, and sometimes prompt them to make sure that they're asking for everything they need to get the care that they deserve. So we're very proud here at St Catherine's to be the first hospice in the whole of the UK to attain their Veterans Aware accreditation. There are 3 levels of accreditation within the scheme: bronze, silver and gold. And as this has recently been rolled out, as I said, to the hospices and care home sector, we're currently at a bronze level of accreditation, and we're working very hard at the moment to go in the spring of 2024 for our silver accreditation. The accreditation means that we've attained certain standards, our ability to identify patients and carers, identify the staff, and that our staff have undergone a level of training and education that gives them slightly more skills to be able to care for these patients. We're committed in providing the best standards of care for the Armed Forces community based on the principles of the Armed Forces Covenant. So, that's one of the examples of the social media posts that we're doing to raise awareness. So I'm short on time, so I think the key thing about what we're trying to do here is make sure that we identify all the patients that come into our care, and that to do that we have built in some questions into our assessment process and some processes within the hospice that then champions are alerted and processes are put in place so that people aren't missing out on things that they could get as part of this community. So in summary, where we are is we're going for gold. This is just the start. We're at the start of this journey. We want to network as far and wide as we can, make connections, and ideally be able to develop some services that are bespoke for patients with life-limiting illness. I think what I've found through all my years in working in specialist palliative care and end of life is that it's not until somebody gets a diagnosis of a life-limiting illness that they then actually realise what it's going to be like. They can imagine how things might be in the future. They can have wishes and preferences, but until it hits them. And I think what I've seen, certainly in my hospice journey so far, is that at the point where patients get life-limiting diagnoses, some of the things that they've experienced in the past through their service, some of the ghosts of the past, perhaps one gentleman said to me, come right back to the future, and they hit them now. And I think sometimes if we're not able to deal with that, then that will then stop them actually living their best life, however long that is, whilst they're actually completing the end of their life journey and receiving palliative care. So we need to do our best for this community, and that's our aim. So thank you very much.
Thanks very much, Michelle. I feel very humbled for everything you've just said, and as a chief exec, you've got such a brilliant deputy. Brilliant. So we're going to now move on really to East Lancs and 2 individuals who again work bloody hard and all the time, always out and about. From East Lancashire Hospital NHS Trust, Fiona was employed by HRMC for 9 years prior to qualifying as a nurse in 1998, when she commenced employment in emergency and trauma care. In 2015, she moved to a clinical site manager of East Lancashire NHS Trust, where part of her role was going around all the wards with the trust. It was in 2019, after a veteran in crisis sadly took his own life in a Burnley Park, that she started to delve into what it was as a trust we did for our veterans. And after getting on her soapbox, she took up the role East Lancashire Armed Forces lead champion. At this point, she was the only champion. However, after submitting an application to the Armed Forces Covenant Trust Fund, she was granted the opportunity to employ an Armed Forces advocate and was successful in getting SID. SID. SID is the Armed Forces Veteran Advocate for East Lancashire Hospital Trust, a role he undertook in April of this year. He's an Army veteran serving 22 years in many peacetime posts around the UK and indeed Europe. He was also deployed operationally to Bosnia, Sierra Leone and Iraq. Sid has worked for the NHS for 4 years, and prior to his current advocate role, he was part of the Intensive Home Support Service and COVID Virtual Ward. This was a community-based team and provided acute care for the patients in their own homes and played a huge part looking after COVID-positive patients during the whole pandemic. Fiona, Sid, the floor is yours.
Good afternoon. I'm going to let Sid do all the IT work because I don't touch it. So, Sid and I, as you all know, are the Armed Forces team for East Lancashire Hospitals, and Sid is our advocate. I was very pleased to take up this role for him. I want that one.
Yeah, you can have that one.
We're a large trust in the fact that we have 5 hospitals and we employ over 10,000 staff. We have various community teams out there, and I'll come to those in a moment. We have over 1,000 beds and we have about 700,000 patients, so there's a lot of veterans out there that we come across. We also have the 5 hospitals over a vast area, and it's over about 1,200 square kilometres. So Sid and I do a lot of travelling. We have seen, since Sid started in April 22, up to date about 1,700 veterans, and it is rising exponentially now that we've got a new computer system, which means that the staff in the hospital now have a direct link with us, and they can press a button and it comes through. All the trust staff have been trained, have got learning hub, and they have got teaching things so that they know veteran aware and how to ask the question.
So once a veteran's been identified, some of you in the audience will recognise this pack because we've all shared the information. So every patient gets a personalised pack depending on the area that they've, as Fiona said, we cover quite a large area. So we have to personalise each pack for each patient so they know what services are available to them in their local area. So one of our main sort of roles really is to try and reduce and avoid admissions. So I spoke with our financial department and some of you will recognise the patient level information and costing system, PLIX, which breaks down every cost to the trust right down to the very last and the smallest paracetamol and everything else in between. So they let me know that an average cost for a patient to attend, just to attend ED, just to walk through the door, is approximately £204. And then subsequently, if that patient then gets admitted, it's a further £642 on one of our medical assessment wards. These are just very basic costs. There's a whole host of other costs, as you are well aware, will be incurred. Now, our trust gives every patient that gets admitted an average time of 3 days admission, some less, some a bit longer, but we've worked out some figures just purely on those sort of average times. So an average admission for 3 days is around £2,130, sort of roughly. So in the time that we've been together and done this role, we've, in theory, and this is only theoretical, saved the trust that amount, just with admission avoidance and reduced admission times. Now, obviously, it's robbing Peter to pay Paul slightly, because if we take somebody out of a bed and utilise a local organisation, then another department can utilise that bed. So we are saving money, but we're not saving money. if you see what I mean. So in that time, the 1,700 veterans that we've seen, not all need support. A lot of them are quite happy in their lives. We know that it's only a small percentage that require support. So we've seen 15 homeless veterans come through our ED department in the time that I've been in this role. And we're very lucky in the fact that we have some excellent local organisations that help us with that. We've also helped people with rails up to their door, that kind of thing. I know Chris over at the back from St Paget's Hospital does a lot of that as well. I'll move on.
Now we're looking at sustaining the service, and apart from getting involved in the veteran groups and collaboration with other trusts that we have taken part in, we've done a host of events just like everybody else. We've internally and externally held meetings and celebration events. We've put newsletters out. We've got the Trust website up and running. We've got social media. And as I've said before, we've done training and awareness. We have got a staff network of champions, and we will be doing quarterly meetings with them and seeing how we can take it not only into the wards, but into physios and other departments.
So as I mentioned earlier about the costs that we've saved the Trust, it was vitally important for Fiona and I to get out on the ground and speak to some of these organisations you can see on the screen. We're lucky in the fact that the 3 football teams, Burnley Football Club, Blackburn Rovers, Accrington Stanley, all have a veterans programme and put on an awful lot for the armed forces community. I'm going to point out a particular organisation, the 2 H's, just towards the left there, Healthier Heroes. It's a local organisation in Burnley, and they can house up to 22 homeless veterans, and they've played a vital part in helping us when we have a veteran that comes through ED that happens to be, in crisis and homeless.
So currently, this is what we have. We have an armed forces lead and an advocate, and I've got a business case now going through the Trust, and I've said to them that if we stay like this, yes, as a Trust we can maintain, but we can't go any further. There's only so much 2 people can do, and I'm kind of a 0.2 because I already have a full-time job. So my business case that's gone forward is to improve the team for a 2 to 5 year plan and have an armed forces lead, have the advocate, and then have a community SID as well as an acute SID. Because I need 2 SIDs. And an admin support. That way I can go into the community. Because that's my next plan. I want to start going into the community. A large percentage of our veterans are over the age of 60, 70, and they are in care homes, they're in nursing homes, or they live in sheltered accommodation. And it's how do we get them not to come in if it's a social side of it, or how do we know when they come in? So I need to develop this service. I've got an email that's generic, and I'm hoping with the help of people in the community that if they are in a care home and they are coming in, or if Doris is coming in or Fred's coming in, they can put an email to us. It will come to both SID and I, or community SID, and we will know that they are coming in before they get there. So it's more work. Hopefully it will come into fruition, but then we can look on our community patients in ELHT as well as the inpatient ones that we're already dealing with.
So we just wanted to end on some patient and organisational testimonies. There's a few on the screen there. I just wanted to point a couple out. Just this bottom one here where it says you helped save my brother's life. This is from one of our own nurses that works on one of the wards. Her brother was unfortunately homeless, living in the woods. He came in crisis, and with the help of Healthier Heroes, we got him into their establishment and well looked after. And then there's another one there. It says, "Good afternoon, Sid. Hope you're well." Up the top there. That was I've been in the role a week, and It was almost like a rabbit in headlights. I had no idea really what I was doing. So I was learning as I was going. And this chap was admitted onto one of the wards, and he sadly tried to take his life. And with the help of the mental health team and the help of Op Courage, we managed to get him into an establishment that helped him. And fortunately for this chap, he came out the other side. I know, unfortunately, some don't, but this chap came through and he wrote a very nice letter to say that if it wasn't for the support that we gave to him, he wouldn't be here today. And I think the most important thing is going to be shown in this video. Unfortunately, it's not a masterpiece like Michelle's was. No. We've had to do it via phone, so it's a bit of a homemade one, I'm afraid. But we'll give it a go. And the sound isn't the best either, so if you could maybe turn the sound.
Well, for one, I think if this project wasn't there, if Fiona and Sid weren't there, then there'll be over 1,000 veterans and family members that wouldn't have been getting the support that they need and that they require. Therefore, they'd have been left in the community struggling of some description. And likewise for us, if they weren't there, the lads wouldn't get the help and support that they need. So it's absolutely incredible what they do. It really is. Financial stability, and I think East Lancs Hospital Trust, Fiona and Sid in their role facilitates a lot of that as well, because people who have been street homeless do come with physical and mental health issues, so the work that they do enables us to be able to link in directly with them. They then support them, stabilise them, recover them medically, which then allows us to do our job. So the partnership between the two just works so well. And like I said, they really are a gold standard service in terms of veterans and family members within the hospital trust setting. And we can't thank them enough for what they've done for us.
How did you come across the East Lancashire NHS Trust Armed Forces veteran team?
I went in with obviously a medical condition, and obviously before I knew that they were there, if you want to come around and said obviously I was from Bancroft House. And then obviously she fast tracked me and obviously looked after me, made sure I was obviously had the right medical attention. But yeah, I didn't know anything about the NHS veteran support or anything like that until I come here.
Okay, and how has the team made a difference to your life?
Well, if it wasn't for them, I wouldn't have got the medical care. Obviously, because obviously I've got really bad depression, PTSD. Can't do wrong people, so obviously if it wasn't for the veteran place, I would have got obviously treated. So they did save my life, to be honest.
I think that video at the end there just shows how important the services that we all provide are, and we need to continue this on into the future. That is our presentation. Thank you very much. And there's some idiot in a uniform there. Yeah, no, they do.
Great homage there. Firstly, thanks to Fiona and Sid. I mean, what a great partnership. That's the first thing, I think. It's like a married couple, isn't it, really, I suppose? And you're doing some great stuff there. Absolutely incredible. And let's hope you can get another cute Sid, is what I would say. Thank you for those who picked that one up. Right. Next, really, as way of introduction, is I want to introduce you to Bernadette Knight, or B, as she's known. B is an experienced senior NHS manager who's been registered nurse for 40 years, joining the NHS and training at the University of Wales. She specialised in intensive care nursing and worked in Cardiff, London, where she gained a postgraduate ICU diploma, and Bristol before moving into clinical research. Therefore appeared outside the NHS in national and regional roles as Deputy Head of Nursing and Head of Care for private and third sector providers. She returned to the NHS management in acute community ambulance, mental health and primary care for both commissioners and providers, focusing on quality, patient safety and service improvement. B is formally trained in quality improvement, methodology, project management and information management. More recently, she has been working as part of GIRF for Professor Tim Briggs across multiple specialities, including the VCHA programme, which we're very lucky to have you, Bea. The one thing I would say about Bea is she is my work wife, without a doubt. Helping her today is Ed Bramley Harker. He's the co-founder and director of Edge Health, an analytical firm that works with leading health and life science organisation. Ed specialises in using economics and data analysis to help operational and clinical teams make evidence-based decisions and improve their effectiveness. He has spent more than 20 years applying economics in the healthcare sector, working predominantly with NHS organisations. And before I hand over to Bea and Ed, I just want to emphasise that this presentation is delivered within the context that this is a pilot and is at the start of the journey, and that's really important. And as such, it's about establishing the framework for data capture. That is really important. Hopefully I got that right. Bea, Ed, the floor is yours.
Okay, I'll do the button.
Put my high heels on because I realise this is a really high thing, and if I didn't have them on, I'd be down like this. So, really great to see everybody. Thank you. I recognise it's the end of the day. I'll try and contain my excitement because I'm very, very engaged in this whole thing. We've been talking about joining the dots all day, and we've had really, really useful and helpful and empowering and encouraging updates from all our partners across the whole system, and that's really, really crucial. Our patients don't hit one part of the system, they bounce in and out in all sorts of different places, so it's really, really important that we do the joining the dots piece. So I'm going to talk a little bit about how we think we may be able to do this sustainability piece. So VCHA, for example, will move into more of an assurance kind of phase, if you like, maybe phase 2, you might call it, as in about the middle of 2024, when we expect and are required to have 100% of our ambulance, acute trusts and mental health trusts accredited to the 8 VCHA standards. So that will mean we've got, and Alex referred to it actually, that we'll have a level playing field as a minimum for all our provider services organisations. They will all have met at least a minimum standard. So we can then use that foundation, carry on the momentum that we've all talked about today to make sure we continue to embed improvement and we build in long-term sustainability of everything that we're trying to do with the overall outcome, which is for all of us, and I'm a nurse, so this is really important to me. This is about patient experience. And it's about making that, what we do, work best for the people who use our services. So we know that there's a whole range of data available to us about all sorts of different parts of our system. Sometimes it's not that accessible, sometimes it's not that clear, sometimes it's contradictory. What we don't have as NHS providers, in our view, is a national standardised core data set that is consistently recorded, reported, used for assurance, used for planning, and therefore that we can all use as that foundation for how we commission and provide services for this group of people. So we know also from other hugely successful what you might call data programs, that using data to drive sustainable continuous improvement works. We have our example from Tim, who's left the room, sadly, who also pioneered and led and drove and continues to drive the Getting It Right First Time programme. Probably, oh, sorry, I'm walking away from it, aren't I? The most successful quality improvement programme that the NHS has seen in a very long time. And Alex also referred to that. So what we're doing is we're trying to look at, can we use a similar model to the GIRF model, so use data, standardised, measured, reported, all of those things that I've mentioned, to drive the continual improvement and sustainability. So with our partners, DMWS and Edge Health, and we're doing a pilot. Now, as Guy said, I don't want you to focus too much on the data, because it's a very small sample, it's currently incomplete, and it's not yet analysed. However, I put money on it that there's some stuff in there that will make you go, ooh, what's that all about? It will generate some thoughts and conversation. What I really want you to think about is, if we had this framework in place and we were able to access this kind of information that we're going to describe to you, and we were able to use that, what benefits would that bring to the people who use our services? How would that help us as service providers to make sure we provide the right things in the right place at the right time, all of those things that we talk about. So I think a couple of other things before I hand over to Ed.
I haven't moved any slides on yet.
No, it's all right, don't worry. No, you don't need to.
Can I just sort of nudge?
No, you don't. I'll give you a nudge in a second. In fact, you can go forward a bit now.
Okay.
Keep going.
Yeah.
Keep going. I just talk, sorry. I get carried away.
I'm
this
trying
one,
to follow,
stop. This is a really important piece, and several people have mentioned it through the day. What we found as VCHA team, when we've been out talking to the organisations that we work with, is that this is a real light bulb moment. And this is one of the data pieces that we talk about quite a lot. It's the demographic. And we talked about doing the right thing by this group, and how by doing the right thing by this group, we also open up doing the right thing, in fact, much wider across the whole population. The light bulb moment is people do not realise what an enormous percentage of our population this is. So we'll have heard more recently in 2021 census that 1 in 25 people in England declared themselves as veteran. That's just the veterans, and I don't mean that disrespectfully, by the way. You know, that doesn't include serving, reservists, families. So we're talking about an enormous group in our NHS potential patient population. That's really important. So with our partners, we want to try and look at, through this data project, can we identify a core data set, and how do we use that to improve healthcare access and outcomes that we're required to do and we want to do? Okay, yeah. And that's the bit there that I just mentioned, and driving the sustainability of that. Can we go again, Ed? What does the pilot look like? Interestingly, and actually not unexpectedly, we started off with more sites signing up than have actually been able to submit data. We kind of knew that, but this has confirmed it. There are currently difficulties for some organisations being able to report the kind of things we want them to report. There's some real practicalities for that. Sometimes it's an IT system, sometimes it's a resource system, sometimes it's that the awareness is not within the trust for staff to ask the question, and therefore we can't then record it. So what we've got, we're down to, at the moment, 6 organisations who are submitting data. We've got professional analytics support, as we've said, from Ed. It's over a 6-month reporting period, so we're just coming up to the final submission in September. The data set, Tim stole my thunder and showed it to you earlier, but we will revisit it because it's worth it in a second, is both quantitative, i.e. numerical, numbers coming through the door, where are they coming from, what's their referral pathways, things like that. The really important stuff for me is what are the outcomes. So we've got significant outcome measures in there. Much currently of the outcome data is going to be provided by our DMWS sites, because NHS is good at numbers, we're not great at the outcome stuff. So we need to try and make that work, because the outcomes are the important bit as much as anything. I will have the joyous job of writing the final report. It should be ready, and we hope it will be ready. We're on track at the moment for certainly by the end of Q4, so March time next year, sorry. And that will inform what we do from that period afterwards, 2024 afterwards. On you go. We talked about those, Tim showed you these earlier. So this is the quantitative stuff that we talked about, numbers, I think, Paul, you mentioned these as well, didn't you, the kind of data that we collect. So it's gender, it's age range, it's all of those things that you would normally expect any organisation to know about their population. Qualitative stuff. Again, this is mostly, not exclusively, but mostly coming from our DMWS sites, partner sites. So did the condition improve? The big one that I've mentioned, how did it impact patient experience? Have we reduced the incidence of mental health crises? Have we reduced delayed transfers of care? Have we reduced readmissions? All of those things. We do have data from, and Tim again mentioned it, from our partner trust in Swindon, which actually supports all of this. Real data from them where they identified, and it's a small trust, they're not big, you know, Alex will know them well, they're up the road from Salisbury. So there are 400-bed integrated community and acute trust. In a 9-month period, they identified nearly 10,000 patients coming through the door who had some sort of armed forces status. So that's just me reminding you that this is a big cohort. What they were able to demonstrate, just some interesting numbers for you, of that 10,000, 66% self-referred through ED. They've then put resource into ED. So in so doing, they've improved the access, outcomes and experience of the people coming into ED. They've improved flow because they've been able to appropriately signpost people who then didn't need to stay in ED as long, didn't need admission. Of those who did need admission, they were already lined up because they'd identified people, just as you had said, Fiona and Sid, about knowing when people are coming in, knowing who they are, knowing what they're going to need when they go home. So we can show that this does work. I guess that's my point, really. So Tim showed you this as well. These are the pilot sites. We very deliberately chose very diverse pilot sites in terms of geography, patient population, the framework they had in place for the Armed Forces healthcare, whether they had Armed Forces advocates, whether they had DMWS workers, whether they did or didn't, whether they were a rehab site, whether they were an opera store site, all different. The only thing they all have in common is they're all VCHA accredited. Next, please. So I'm going to hand over to Ed now, and he's going to show you a little bit about what the data and the dashboard looks like currently. And what I want you to think about is, if we had this information consistently and accurately available to us, what a tool that would be for the benefit of our population.
Can you go this? I don't want to lose you down the steps.
Sorry.
Thank you. Well, I need to begin, first of all, by thanking all of the partner trusts that have been working with us on this. I know we've hassled the data teams in each of the trusts quite a lot to get the data, but it's, I think, a very worthwhile task, and people have been very helpful with us. And also thank you to DMWS for providing the data as well. From the trust side, we've been focusing on collecting what I would call episode level data, focusing on emergency care, on inpatient care and outpatient care. And then from the DMWS side, we have data again that covers all of those areas, but also DMWS does a lot of work collecting data on sort of the qualitative outcomes and patient impact. And the goal really, as B has said, is to use this data to answer a number of questions. So I think you can use the data to get a handle on sort of what's the variation in the demographics of the population that all the acute trusts are serving. You can use it to explore unwarranted variation between acute trusts in how they're managing veteran populations as they go through the acute care pathway. And I think with the DMWS data, we can also explore variations in outcomes and begin to ask questions about what might be driving that. And if you do that, underpinned by data, first of all, you've got an evidence base to draw on that people will get confidence in, and it will start to form the basis of those meaningful evidence-based discussions with clinical and operational teams. It also gives you a baseline to track progress as you move forward. But the first thing you need to do is make the data available to trusts in an accessible way, and this is what we've been trying to do with constructing the dashboard. So what I'm going to show you now is just give you a few examples of what the dashboard looks like and how it could be used by trusts. And as B said, try and imagine a world where we've got 150 trusts on this dashboard and you're seeing all of the variation across the acute sites. So first thing you can see when you go into the dashboard is you can choose what you're interested in. Do you want to look at emergency department, inpatient, outpatient, and so forth. You can tell it which trust you are, and then you can select the period that you're most interested in looking at the data for. I'm going to pick a few examples. So the first thing when you click onto the emergency department dashboard is you get some very high-level stats about the veteran population that is attending at that trust. So this one, 550 ED attendances, median age band of attendance is 60 years, so the median age of the veteran is 60 years, and they're waiting about 92 minutes to be seen in ED. If you compare that to another trust that submitted data, very different age profile, 20 to 25 years is the median age in the second trust, much shorter waits in ED as well. And I was quite surprised when we dug into it to explore how different the age profile of the veteran population accessing acute care is. So this is just an example for two trusts. Maybe it's not surprising, but I was quite surprised that it was that different between two trusts. And I think that raises lots of questions then about how are the trusts and the wraparound services that support healthcare more generally engage with their veteran population. This is the proportion of ED attendances that arrive by ambulance. This is focusing just on the veteran population. We can measure things around what happened after the ED attendance. So did you get admitted? Were you discharged? And if you were discharged, where were you discharged to? I think there's probably some issues in here in making sure everybody's using all of the codes that they can in the data, but you can see what's possible if you start to explore that data. I thought this was interesting. So if you're a veteran and you get into an acute bed via the emergency department, your length of stay in that bed can vary quite widely. And we all know that once you get into an acute bed, it can be quite difficult to get out. So I think there's big questions here. First, about should you have been put in an acute bed in the first place? And second, what are the support services that need to be in place to help expedite discharge? Linked to that, this is looking at people who are in an inpatient bed, veterans who are in an inpatient bed in a trust, and looking at the proportion that come through the emergency department. So again, that raises questions about who's accessing inpatient care through an emergency pathway versus a sort of normal elective pathway. Through the DMWS data, we can explore issues about, well, what are the health issues that people are arriving in hospital for, and what is the impact of those issues on their kind of day-to-day activities. And that gives you a sort of a sense of what people are likely to be presenting with and what's important to them. And DMWS also asks questions about what's been the outcome once you've been in contact with the acute sector. So how have you benefited? And again, if you can imagine having that across all of the different trusts, I think that's a really rich data set to kind of explore why outcomes vary. And this is just one example of how you could explore the outcomes data in more detail. So we've got 4 trusts here. Column on the right shows the proportion of patients that are reporting an improvement in well-being. Now, I don't actually believe all of this data. I think there's probably some coding issues in there because there's big variations in the number that are reporting an improvement in well-being. But imagine if you had that for your entire veteran population and could start to do those comparisons. So I've got 2 minutes left, which conveniently means I hand back to B.
So I suppose there's a few things I'd like to kind of leave you with. So the big thing is, if we don't know our population, we can't meet their needs. So a really fundamental is that we need every organisation, whatever their role in the patient pathway, or whatever you want to call it, needs to know their population. And the fundamental about that is all staff need to ask the question with patient consent. That's the caveat. They don't have to tell us if they don't want to. But our obligation is ask the question, so that we can then consider what does that mean for how we communicate with these people, what does that mean for the needs assessment, what does that mean for this person's care plan, their discharge plan, what are their needs that we can then link up with to make sure that their experience is the most successful and positive it can be. So in terms of next steps, we've hypothesised about is this the right data set to capture. So it's something that we will evaluate when we get it all back and see actually what it looks like. We would definitely need to upscale. This is a small project, so we'd need to involve more organisations. Potentially, and I think you mentioned about the hospices, we look at, do we do a similar thing in our partner organisations outside of the NHS? Because, as we say, our clients, if you like, don't just come to the NHS, they get their services from all sorts of providers. So do we look at how we apply this sort of approach in a wider situation? We've already, in the small set that we've looked at, identified quite significant variation. Whether that's about coding or what the issue is behind that, we don't yet know because we've not analysed. But we would certainly, exactly the same as the approach that's used in GIRFT, we'd want to look at where is the unwarranted variation, and if it's unwarranted, what are we going to do about it? So, again, similar to GIRFT, one of the things we might do next is pilot visits, site visits. We might, as they do in GIRFT, prepare the data packs like Ed has described in the dashboard, take them to the submitting organisation and say, this is the data you've submitted, this is how you compare to your other organisations, this is what it looks like, this is what you're doing well, this is what perhaps you'll need to have a little bit of a look at, this is what works well over there, will you be able to apply this best practice in your organisation? That's the approach that GIRFT uses. We don't know if it would work in this scenario, but we're going to think about it. And then obviously at the end of the, in the report, we'll make recommendations. Which one is it, Ed? Is it that one? So, ultimately, we want this to be business as usual. So what does that look like? So, again, just as organisations already do, submit data sets regularly to platforms, things like the HES data and all of those things that we've mentioned. So we would like all providers to submit the core data set regularly to an agreed platform. We don't know what that platform will be yet. It may or may not be Model Hospital. What we don't want, we know what we don't want. We don't want it to be in isolation from other activity within the hospital. So what we might do, because Model Hospital's got quite big, and we want this information to be really accessible and usable for everybody in their everyday management time, you know, when they're working. So we probably link it to Model Hospital rather than put it on Model Hospital. So we want organisations to use this data to monitor, to assure and to act upon. We want to use this kind of approach to establish that sustainability and continuous improvement that we've all talked about, ultimately for the benefit of patient experience. I think that's it. Oh no, it's one more, sorry.
There is one more.
That one? Yeah. Really, it's full circle. So we come back to the end state. We want to deliver the National Universal Core Reporting data set. We want to be able to demonstrate through that data set impact, measurement of effect. We want to make sure that we have ongoing continuous improvement and quality performance. We want to drive down any variation. We want to allow organisations to be able to make early assessment of needs. And in so doing, potentially, Fiona and Sid have mentioned financial savings. And those financial savings, you know, we can reinvest them. We can, you know, if we are impacting as we think we are on readmissions, unnecessary admissions, delayed transfers of care, then we improve flow. So it's not necessarily a pound note benefit, but it certainly is in terms of activity, quality of care and performance. So ultimately, we want to sustain the programme in delivering our requirements of the Armed Forces Covenant and our moral obligation. Thanks very much.
You know, health and well-being for obvious reasons. So, has anyone got any questions for the panel? Yes, JJ.
I've got a question for yourself, H. I'm Johanna Ritz, Armed Forces Advocate, Mercer Hospital, but also Royal Army Medical Corps, 25 years. I know from first-hand experience in the military that the old mod form 510s were very rarely filled in for someone hurt themselves within the military's time, especially in the reserve space. So when it comes to accessing Opera Store, to what extent, if it's not documented as a service-related injury, and it's almost impossible to go back and prove that, to what extent can we support veteran patients into proving it was service-related, or if it can't be proved because there's no paperwork to support it, what happens at your end? So that was the first question. The second one was, if someone's we will see them if they're already in the NHS. Is it advisable to keep them in that stream or to pick them out and then put them in your stream? Is there any benefit to the patient for doing that? Thank you.
Cheers, JJ. So I think everyone heard the question. The second question was, is it worthwhile referring to Opera Store if you're in a physical healthcare pathway? I would say yes, because even though the actual physical healthcare pathway may not change, so about 40% of the people in Opera Store are already in NHS pathways which we do not change. But what we add is the DMWS, veteran support worker, the wraparound care that military charities can provide, and often that link into Opera Store. So, though the physical health bit may not change, that holistic element is in addition, which is often of huge benefit. The first question, which was about how attributable, how can you prove, whether an injury is attributable or not in service? We're pretty pragmatic about that, just because, records transferring across, as you say, is difficult. So we will take a very pragmatic view on that. I mean, the constraint for us as the NHS is we're meant to be putting people into a veteran-specific pathway only for attributable injury. But a bit like your second part of your question, if a referral comes in and we think actually this probably isn't attributable, we can still lean across to DMWS and say, actually, there's some wraparound here, we're in the right pathway from a NHS perspective, physical healthcare perspective, but there might be additional benefits. Having said that, one of the things we get pushed on is MSK, wear and tear type injuries. And again, it's pragmatic. If we're seeing someone in their 40s who's needing a knee replacement, who spent 20 years as Royal Marine, Airborne Forces, SF, whatever, chances are that service attributable, even though it's not documented anywhere. So we try and be pragmatic. Even if we can't, or if that patient doesn't need to be in a veteran-specific physical health pathway, I think there's still huge benefits. And I think the real gold dust, what we do, is that holistic link in.
Great. Any more? There was, sorry, hand at the back there. She's going to pass you a mic.
It's a question for B. Can I just ask, was it just Acute Trust that were the pilot and not mental health?
Yeah, at the moment.
Is there a plan to do it in mental health,
yeah,
only trusts?
That's one of the things we plan to look at, widening the scope of, but we want to identify the core data set first as best we can, and then look at how that may or may not apply in other kind of service providers, whether they be community, ambulance, mental health, third sector. We don't quite know what that will look like, but yes, we do hope to widen the scope, yeah.
And I think can I just add, NHS England, we're also funding a 2-year pilot specifically to look at 4 streams across the data set. So one is the physical care pathway, of which the work that B's talking about is a part of that work that Rob Munro, that those of you will know Rob's working on. Because there's 2 things. There's the valuation that B's talking about, as well as the sustainability programme. We're doing it into the mental health area as well, because that's about the common shared care record. Maternity is another area we're looking at, particularly affects serving people as well as transferring people, and there's a specific piece of work around that. And then the 4th data stream area is around op community, which is the family element of it. Again, that's mobile families and resident families, and that's as much about assessment as well as the core data sets that go with it. And that's already running. Those bits of work are already running.
Great, thanks, Richard. Sorry, there's a hand at the back.
Yeah, hi. Sorry to ask this question, but it's probably one I won't be able to get an answer to either this afternoon, but we'll try and give it a go, shall we? Police forces up and down the country record real-time surveillance, suspected suicide surveillance data up and down the country. And when there is more than one in a local community, it's deemed to be a hotspot in that community, which the police then have to further investigate why, or is the potential linkage. With regards to the armed forces, we've seen recently about information about certain regiments deployed overseas, and on significant anniversaries there's been associated deaths by suicides associated with that. Bearing in mind the Royal Anglians are observing in my part of the country a significant anniversary at this moment in time. What is the actual plan to help reduce reduce deaths by suicide in the future? And I understand next week in Manchester that the suicide bereavement are launching a suicide bereavement toolkit, but is that really about prevention?
Yeah, so can I just dive in on that one? It's a really interesting and important point. So there's two parts to that. In the early prevention element of it, and that's the key part, and Jonathan talked about that earlier, Jonathan Leach talked about that. Part of the work we can do with Op Courage is to make those services aware of key anniversaries when they're coming up. And we've done that over a number of particular anniversaries. We've done it over Southern Atlantic. Recently, we've done it over Libya. We've done it over Sierra Leone. We've done it in Afghanistan. We've done it over Libya. There's Iraq. There's a number of times we can do that. And of course, if you can upskill the clinicians as well as the professionals to support working with the regimental associations, because quite often they're the ones with that key information to come to help us with that information. So that's part of the prevention side. You're right, next week, that the work that Sharon McDonald has been doing on the collection with the really important voices that have been brought into the suicide on the bereavement side. And basically there are going to be 3 sets of guides. So one is for veterans and one is for families. They'll be broadly similar with a national set of bereavement guides because it's important, but with some contextual nuances to support professionals. And then the third guide is for the armed forces themselves, which needs to fit in with their existing policies, which of course is done at regimental level, up through unit level, up to single service level at the same time. So they're all going to say roughly the same thing, but they'll be slightly nuanced, which means they're relevant to the people that need to read it, as opposed to being just one big, huge document that exists. And I've seen early sight of them, and they're really useful because you can pull out individual sections, individual elements of it. You can read it together. It acts as a sort of advice and guidance holistically as well as specifically across a number of areas. And within that, the really brave voices of those people that came forward to inform that work, it needs to be captured and will be referenced in that as well. Hopefully that helps a bit.
Yes, Jonathan.
Can I ask you, I'll try and shout. I suppose it's a question for everyone really, that we talked about how we outside, when people become veterans, are made more veteran aware in organisations. Is there a move being made to help those who are currently serving to be aware of, veteran aware when they leave? Because I'm very conscious that people hit that point, and I was one of those people who left and went, I've got no idea what's going on. We can have all of these organisations up and running, fantastic, so many people passionately working towards it, but actually those people who are leaving aren't aware of it until they hit a crisis point.
Yeah, so in broad order, nobody needs the health system until they need the health system.
Absolutely.
Yeah, and so using a number of processes, and that goes back to regimental associations, which are really important within the Army context, but that would be the same for the Royal Marines Association Charity, for the Royal Marines, Royal Naval Association and the IRAFA. And also working with units who are serving and using the Career Transition Partnership. And then working with those people that are already in the wounded, injured and sick pathways, defence recovery capability to support them, as well as working with the families federations to support the families. You're never going to hit everybody, but if you don't make a start, at least you've got an option. And of course, then people, as H referred, will come in later on and don't know they necessarily need it, which is where the accreditation programs come in, because that's when you can support professionals to help ask a question. Now, we're not going to ask 65 million people have you served, but you can make an informed discussion with individuals to help support those pathways.
H?
So I think it's a really good point, and it comes back to the theme of the day of like linking up and joining up, and obviously one of our key partners who don't operate in the veteran space is the MOD. Because obviously, the transition piece, if that's done well, the problems won't get passed on into the veteran space. So as Rich said, apart from all of those initiatives, we're working really closely with them to make sure there's awareness at point of transition that if you've got someone with an ongoing physical health care need or mental health care need, there is a preemptive referral in to the relevant pathways, Op Restore, Op Courage. So, we're now beginning to get people before they leave service referred into us, making sure they get registered with GP, and we're trying to get a line in the discharge medical. Does this person have any ongoing physical or mental health care needs? Have you referred on to? Because I think there is a employer responsibility on behalf of the MOD to make sure these people are transitioned well. And as Rich said, I think there are lots of moving parts in this, but I think the conversation is becoming much more collaborative. And it's also helped, I think, that we who sit in the veteran space, both military charities and statutory bodies, are a bit more cohered. So it's an easier target for them to hit. There's kind of, a single place they can go to.
I think it's very much the people who are going through the transition periods, those people who are already in the system, perhaps having mental health issues or physical issues, but it's the people who are not in that arena first. So almost having, let's take the Army as an example, but regiments becoming veteran aware, almost accredited whilst they're serving, so they know what message they should be pushing.
And of course, the irony here is that the Armed Forces Covenant applies to the Ministry of Defence.
Thank you. Don't go down there. Yeah, sorry, an ambulance service person there.
It's Martin.
Sorry, Martin.
Armed Forces Advocate at Airedale. Been absolutely brilliant today, and yeah, I've seen a lot of the dots are joining, but there's one dot that I see missing, and that is alcohol or substance misuse. Now, yeah, we do come across veterans, and I have read data that shows that it's twice as, there's twice as many veterans are likely to be alcohol dependent. Not necessarily mental health, not necessarily coming under College. Now, what support is going to be available for them, and is that data going to be starting to be collected?
Richard?
Yeah, so, I mean, it's a really important point. So quite often you can't disassociate from the mental health issues and the impact on families and the impact on the carers that are going with those issues, both serving and for veterans. And of course, we have to recognise that it's an in-service issue, and it's a key part of the health and wellbeing leadership team, one of their core sets of activities they're looking at in the MOD. So the services, though, are local authority responsibilities, as we know. So our requirement, and a lot of the work that we're trying to do, is create better awareness for the understanding of where that needs to exist. It's not, unlike all these things, they're not things you can necessarily switch on straight away, as you know, but where they do exist, and particularly where you've got places like Tom Harrison House and places like that exist that can support that activity, that helps us tremendously. It's not going to be an easy fix, but the evidence within those pathways is helping create better joining up in that system, and it is definitely on the radar, if I was using a military analogy.
Great, good stuff. Thanks. B's got a point.
Yeah, Martin, you're right, important point, and we know the kind of incidence of this sort of problem. The short answer is, as Richard has said, but in addition, it may well be part of the widening scope type activity, which we haven't fully fleshed out yet. But because it is such an important element for this group of people, it won't be overlooked.
Paul?
As part of what we do within DMWS, we obviously come across quite a lot of casework that has alcohol as an element of what the person's challenges are. And that's where the local knowledge of the people embedded within the system to know what the local facilities are available, what groups are available. And it's not only alcohol, it's other substances, and on the rise is gambling, especially for the younger cohort. So where we are picking up people, we're absolutely picking up that challenge. And of course, if we get the data right, we can correlate that nationally and start to put other solutions in place to address it.
Thanks, Paul. Emily, did you want to come in?
Yeah, I was just going to add from the primary care point of view, this is one of the parts of our training packages for newly accredited practices, is recognising that veterans may be more likely to use alcohol, for example, as a coping mechanism, and so hence why it's really important to ask if someone's a veteran, and then that'll open up other possible referral pathways.
And I need to do shout out full step, because go back to joining these two questions together, using veterans in all roles across the NHS where they can stand in and support gives you an additional contextual voice and hearing that you can't replicate that any other way, and that really helps, because then they know where to go back to ask the right questions into other organisations. So these are all mutually supporting. Those quite often you don't quite see where the two dots join.
Great. I'm going to have to draw stumps there. I'm sorry. So, panellists, thank you very much. For those who weren't involved, I apologise. But if you can grab your seats now, and then I want to just set up Colonel David Richmond. Right, David's always last. Sorry, David. Just in way of sort of introducing David, for the closing address. Colonel David served in the Army for 26 years, deploying on operations to Northern Ireland, Iraq, operations Granby and Telic, Bosnia and Afghanistan. He commanded 5 Scots in Afghanistan and was seriously wounded. He underwent 4 years of reconstructive surgery and rehabilitation. He was medically discharged in 2012 and joined Help for Heroes as their first Director of Recovery until 2017. In 2019, he was appointed as the first interim Director of the Office of Veterans Affairs in the Cabinet Office, and in April 2020 he became the first independent Veterans Advisor and Vice Chair of the Veterans Advisory Board. David.
I'm amazed there's so many people still here. Blimey. And that's not a reflection on the day, I have to say. Guy always does put me on last. And I said to Guy the other day, I said, what do you actually want me to do? He said, well, give your reflections on the day. And that's a real bummer of a job because, of course, you can't prepare your reflections. So those of you who've seen me scribbling away, is me trying to think out what my reflections are. The challenge I have is, can I read my writing? Firstly, a little bit about today from my immediate first perspective. I think it's been a really, really good day. It's been absolutely fascinating. I'm your 18th speaker, and that doesn't count all the panel session. And I know I am the only person standing between you and the pub or a coffee or your train. So suck it up. This is where I now need to read my writing. I have no slides because I couldn't prepare any. And even if I had time, I suspect I wouldn't. And I really have no idea particularly about what I'm going to say specifically, but you're just going to have to bear with me. I will say a little bit about my role because it's not well known really. I mean, Guy alluded to it. I'm the first into this independent advisory role. What would I say about it? I'd say the key word in it is independent. I am not a political appointee. I'm not here for any political reason. I'm not involved in politics at all, thank goodness. And neither am I a civil servant. So what that means is it gives me considerable leeway to get involved in things I'd like to get involved in, quite often things I don't want to get involved in, but to give honest, frank advice, insight and challenge, not according to anybody's party political line. I don't need to toe any line. That's quite a nice position to be in. That's a little bit about the role. People say, well, what do you actually do? Good question. When I started, nobody told me what they wanted me to do, so really I've just made it up. I think there are 2 aspects to it. The first is to get out and about, to meet people who are veterans, to meet people like you who support veterans around the country, and understand what their perspectives are. What are their experiences of the systems that they're trying to work within or trying to access? And then at the other end of the spectrum is to talk to ministers. Well, I talk to ministers about my experiences there, of course, but also to try and highlight to ministers areas where I think there are some strategically important areas that they need to focus some of their attention. A recent example would be the review of Vets UK and the necessity to get that right. That was the consequence of a lot of discussion around how we get this better. On to some reflections, so you're just going to have to bear with me. My first, I think, reflection is that we really do, when I say we, I actually mean you, should take considerable satisfaction from the huge amount of work that's going on in the healthcare sector, health and social care sectors in particular, that is focused on supporting veterans. If you just scan through the programme, you get a feel for just how many initiatives that are going on. It's quite simply extraordinary. GP accreditation, Op Courage, VCHA accreditation. Goodness, I could list them. I won't because there isn't time and somebody's going to flash a card at me shortly, I'm sure. But there's a whole host of things that is going on. And there's a lot more to come. And I'm acutely aware that actually so much of this has been achieved because of the leadership of people in this room, both those who sit somewhere near the top of the NHS hierarchy and those who sit in positions in local trusts and local third sector organisations. And somehow, in this sector in particular, we've seemed to have managed to blend strategic leadership at one end with autonomy and initiative at the other end, at the local level. And it's generated all the things we've talked about today. And I think so much of that is so very, very good. And it's really hard to do because you need to have trust in each other as a sort of healthcare system, not to try and over-control it. And I'm a big advocate for not over-controlling things, because if you over-control them, you stifle them. But yet you still need some control. You still need some form of framework. And I think what the VCHA is doing is providing the framework within which you can all exercise your initiative and generate the services that we have talked about today, and which I won't reiterate. You know, I've said, those of you who've heard me before, I feel for you, I'm sorry, but I've said this before and I'll say it again. You know, the support that is available to veterans and their families now is simply unrecognisable compared to what it was in 2006, 2007, when we really got our arms stuck in the mangle both in Afghanistan and Iraq at the same time. It's unrecognisably better, and it's so easy for us to forget it, and we mustn't. You know, we should be really proud of the changes we've made, and none of what we have talked about today, what you have talked about, the achievements that you have made, existed in 2006, 2007, 2008. I think back to my time at Selly as it was then, and then through Headley Court, and this stuff in this room didn't exist. It wasn't there. And if you had said to people then, could you achieve all this? You'd all have said, you must be joking. Well, it's done. And I think we mustn't forget it. And we should be proud of the changes that have been made, but not in any way complacent. I don't think complacency is part of it. And we need to keep driving forward the changes we want to see. And you know, we've heard already today that a new initiative is the VCHA Rehab Initiative. Wonderful. For years we've said once you fall out of Headley Court, there's nothing really in place because the NHS doesn't really do rehab in anything like the same way. I know that's a very broad statement, and you can always point to certain things in certain places, but it doesn't. Well, we're about to see if we can manage it in some way or another. Isn't that great? And I think also, and I'm conscious of Nikki sitting here, and I'd had this in mind anyway, you know, the patient participation group. You're leading the way in involving patients in calling it a participation group, involving them in what it is that the system, the NHS system and others, is trying to do. And that doesn't really exist anywhere else in the same structured form where it's formally locked in, it's properly supported, it's properly resourced. And we could all point to areas, not just of that, but across the system where it's not as good as it might be. And of course, that's why we're here. But let's not forget the things which are really good and which are continually improving. So that's the first thing I'd really like to say. I think also that despite some of the challenges that people have experienced in the NHS with the pressures of COVID, the cost of living pressures, the budgetary pressures, the strikes that are going, all these kind of things going on, and all the rocks that people chuck at the NHS continually, because you're an easy target, and that's why people do it. I feel that the pace of change, if anything in this area, has increased. It hasn't slowed down. And I think that's a really good thing. There is an aspect of let's steady the horses every now and then and make sure we're on the right course and speed. But that pace of change has not stopped. And I think what drives the change, and I go back to what I said a moment or two ago, is the blending that you've managed to achieve wonderfully well between that strategic leadership and the framework and allowing people who've got all the good ideas to have a crack at it. And if it doesn't work first time, either stop doing it or change it. And people have been allowed to do it. And I think that has generated this sort of innovative approach that you have. I'd also say that we're in a lucky position for now, and this perhaps coming back more to the role I currently fill, is that we have a minister whose ugly mug was a bit close to the screen earlier on today, who cares deeply about this. He's passionate about it. And that's why I enjoy working for him, because he is genuinely interested. You absolutely need somebody like that in that role if you want to drive change and you want to get stuff done in Whitehall, because Whitehall is Byzantine at best. And if you've got somebody who's not really interested, nothing will happen. So the leadership that politicians choose either to offer or not is absolutely decisive in what you might achieve. And you've got somebody who wants to do it. I'm just to ignore that. You've also got an OVA which has established itself. It's growing in capacity, it's growing in capability, and is now capable, I think, over the next few weeks and months, of looking forwards and driving some change across Whitehall and not just answering the mail, which is where they've been rather stuck for the time being. I should highlight that there is a sort of there's a coming period of uncertainty. You know, in the next 15 months there will be a general election. We know that because we've got to have one. Don't let it surprise you when it happens. What do I mean by that? What I mean by that, it might surprise a few people, not all in this room. We have to plan for it. If you want to sustain the pace of change that you have and the innovation that's going on, you have to plan for it. We've all got our views about how the election may unfold, and I suspect a lot of us might agree on the likely outcome. But what we do know, and is a reasonable assumption, is that political attention will switch post-Christmas, if it lasts as long as Christmas. And they will start to focus much more on campaigning and much less on getting their day-to-day ministerial jobs done. And see, this is the advantage of being independent. If I was a civil servant, I couldn't say that. I'd be saying ministers will continue their normal job. They won't. They'll focus on campaigning. Of course they will. And once the date is finally announced, this thing called PERDA descends on the whole world, and nothing happens because they can't. They can't take anything new forward, and they can't announce anything. There are opportunities and there are challenges in that. So I'm going to highlight to you the challenge is that if you want ministerial or OVA support to a new initiative, get it in now. Get it in soon. You've got until the election's announced, because after that they'll be thinking about other things. And actually, after that, they can't announce it or do anything about it anyway. The opportunity is if you get it in early, then the chances are if it catches the selector's eye, they will drive it forward really fast because they will want to talk about it. So that's just the fact of it. You might not like it. Doesn't matter if you like it or not. That's just the way it is. But that's what you've got to play with. That's the field that you're playing on. And of course, those of you looking towards the election, if there are any in the room, there are discussions to be had with all sides about manifestos and what appears in it. If you want to get something in there or get them thinking about something, have those conversations. But as I go back to what I said at the start, don't be surprised when it happens, because the election's coming and it will change the context we're operating in. If I turn back quickly to what we've heard today, inevitably a lot of what people have talked about is focused on England. Veterans served the UK's armed forces. They did not serve the English armed forces. One or two people have alluded to Northern Ireland and other places where there are some initiatives. Could I just ask that if you're in a position to do so, and I know you're not all in that position, but if you're in a position to do so, you look beyond England. You look to see how you can support people in Northern Ireland or Wales or Scotland, or to share best practice, particularly Northern Ireland. The Northern Ireland veterans living in Northern Ireland feel like the forgotten army, because the political situation, the security situation puts dreadful constraints on what is an offer and what can be offered to them. If you can use your initiative, find a way to support, find a way to lean in. One or two, I think H talked about it a bit today, and one or two others. Please think about how you might offer some support. I'm going to finish off in the next couple of minutes just by talking about what I call the 4 C's. Things that I think don't just apply to the people in this room, but across the veteran sector as a whole. What are the 4 C's? The first one is complexity. We've alluded to it already. In fact, Alex talked a little bit about the tapestry of care and the complex nature of the environment we work in. The veterans ecosystem is hideously complex. It's hideously complex to the point of being described as nigh on impenetrable by those who are not used to navigating it. And a recent review of Veterans Welfare Services used those exact words. It is nigh on impenetrable for people who don't know how to navigate it. Everybody in this room, to some degree or another, exists in that ecosystem already. You are familiar with it. You won't be familiar with all of it. Very few people are. But you will probably have challenges navigating it at times. If you're a veteran trying to access this for the first time, it's a bummer. It really is. So as you're designing services, thinking about comms, trying to understand what you put together, really think about what that looks not looks like not to you, which may make total sense, but to somebody who's never seen it before. I describe the veterans ecosystem occasionally as a bit like being handed the IKEA flat pack instructions. The instructions are clearly written by the man who designed it or woman who designed it in the first place, not for the man or woman who's never seen it before. And if you can just hold that thought when you're thinking about how you evolve in future, then I think we're starting in the right place. I think it's fair to say the sector will never be simple. It's just not going to be. I think I'm always in for a grand ambition, but that is an ambition that's probably too far. It won't be simple. The nature of it just isn't. But we have got to, between every one of us in the room and beyond, do everything we can to make it simpler. Simpler for people trying to access it and easier to navigate. The second C is coherence. We could all probably quote at least one area of the ecosystem, even within the bit that's in this room, where there is incoherence between parts of it or between different parts of the same organisation, and that's often the case. And I'm not poking fingers at anybody in particular. Sometimes that's just how organisations evolve. This is driven by a host of different factors, with sectors being made up of statutory bodies, third sector organisations, CICs, goodness knows, Uncle Tom Cobley and all, is all mixed in. It's going to be complicated. But when we're looking at developing the next lot of initiatives, simplifying the ones we've got, etc., 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 let's look at coherence. I think we are a long way down the road to improve coherence, just from the conversation today in here. But I would say we have this ambition, there's a government ambition to make the UK the best country in the world to be a veteran. I think that's great. Some people don't care about them. I think it's great. Because if it's not that, what is it? Why don't we all aim at that? Instead of making it the government's vision, veterans are the nation's veterans. They aren't the government's veterans. They're the nation's veterans. If everybody hooked onto that vision and started to think, what's my role, our role in delivering that vision, we're starting to generate some cohesion. We're starting to focus on a singular purpose. And I think that would go a long way to creating improved coherence. The third C is collaboration. I'm utterly delighted that today collaboration has probably been the most used word. It wouldn't have been a while ago, would it? I think most importantly, not just the use of the word collaboration, but the whole tone of the discussion around it has changed. Before it was something people, I think, felt they needed to say. And too often what it meant was, I'm very happy to collaborate with you lot, provided you do it the way I want to do it. That isn't collaboration. And there was a lot of staking out of turf going on. And we'll collaborate up to there, and then we're not collaborating anymore. Today, I think we've heard so much about collaboration, about people genuinely leaning in towards each other and understanding and working towards how they can make things better together, towards partnership. And I think actually Kate Davis earlier today was talking about working towards partnership or something of that sort, some form of words like that. Absolutely right. Let's make the whole greater than the sum of the parts. And I really feel that the whole tone of collaboration and the talk about collaboration has changed for the better, even in the last 12 months. And could we take it a bit further forward, do you think? Can we take it from collaboration to integration? Can we properly integrate? This is an area I think, and I've said about Kate before, has led on with commissioning that is reliant on one charity, at least a charity being involved in delivering a service. That's really good. Let's take that. The third C, that is the third C. The fourth C is communication. And you'll be glad to say I said 4. I'm at 4, so I'm nearly finished. We must communicate better, is really my thought. We've got to communicate better to veterans and their families. I go back to my IKEA flat pack instruction sort of example. This is an area that actually it requires greater collaboration in how we communicate collectively and individually. Government comms, quite frankly, is a bit crap. It is awful. It's in language nobody understands. It talks about policies nobody's really interested in. It's not meaningful to a soldier, a sailor, an airman, or a veteran at the far end. It's Whitehall speak about Whitehall stuff, generally. We've got to do better. The single services, I've scribbled down here aren't much better, actually worse, I think, in many ways. And for big organisations like the NHS, it's really tough, but we've got to be better. We've got to be more frequent. We've got to get rid of the overly complex language. We've got to think about who's reading it. The average reading age for an infantry soldier is 7. 7. Think who's reading this stuff. Got to communicate better. And my last plea about communication is let's get the facts right. We've talked about data. We've talked about information. We've talked about using data to drive things forward. Because comms isn't just about telling people about the services we've got, how to access them. And I appreciate entirely, and I wouldn't I, given my background, that charities need to raise money on the back of what they do. You've got to be right about what you say. Don't make it up. Get the context right. And let's not forget that although we work with those veterans who need help, the vast majority of service leavers leave well. And they'll never be in your hands at all, ever. They're a benefit to society. So let's please not leave people who don't know any better thinking that everybody who's served is somehow broken by service, because they're not. And I think that's a really important point. I'm going to finish by thanking Tim, who's not here. He got bored early and left. Guy for organising it, and of course you guys actually for doing all the work that has delivered what I think, from my experience over however many years it is now, are such manifest improvements in the support to the veteran community that you really mustn't forget the journey you've been on while you're looking on towards the journey you want to make. Thank you very much.